Good morning, everyone. I hope you are staying indoor and you are being taken necessary precautions against the COVID-19 virus. So, let's start with today's class. In today's class, we'll be talking about the cephalosporins. As you know that we must have covered among the beta-lactam antibiotics, we must have covered a group of antibiotics called as penicillins group of antibiotics. So, cephalosporins is one of the other beta-lactam antibiotics. So the main difference between the penicillins and cephalosporins as far as the structures are concerned, that in the cephalosporins we have got a nucleus which is called as 7-amino cephalosporinic acid nucleus. Okay, 7-amino cephalosporinic acid nucleus. Okay, so if we go a little bit in the history, the first source of cephalosporins were from a fungus known as Cephalosporium acrimonium. In 1948 it was extracted, and generally it was used in war-wounded patients, especially for the skin and soft tissue infections. Okay, now there are a few important things about the cephalosporins which we need to know. One is how it acts, then what are the different types of cephalosporin antibiotics which we have got, what are their antimicrobial spectrum, then what are the some important pharmacokinetic properties of these antibiotics, then some therapeutic uses and the adverse effect of these cephalosporins. Okay, so we will cover it one by one. So as far as the mechanism of action is concerned, it inhibits basically the synthesis of the bacterial peptidoglycan cell wall by inhibiting the transpeptidase enzyme. So just like penicillin group of antibiotics, we have got a penicillin binding proteins. So here we have got a different penicillin binding proteins which are for the cephalosporins, and by binding to it, it inhibits the synthesis of bacterial peptidoglycan cell wall. Okay, by inhibiting the transpeptidase enzyme. I'm sure you all are aware of what is the difference between the cell wall of gram-positive and gram-negative microorganism. You must have read in the microbiology. Okay, so please remember it is cephalosporin, one of the other beta-lactam antibiotic, and it acts by inhibiting the cell wall synthesis of the bacterial peptidoglycan and by inhibiting the enzyme called as transpeptidase. Okay, coming to the classification as such, you know, the cephalosporins, they have been divided into, initially they were divided into 3 generations depending upon their antimicrobial spectrum. Later on some more antibiotics were discovered under this group. They were later classified as into the 4th generation and 5th generation. Okay, so the first generation, each generation of antibiotics have been divided into the, depending upon the route of administration, they have been divided into the oral or parenteral. They have been categorized into the oral or parenteral. In few of the books or lectures, you will find that there are some mnemonics which has been given, that how to identify whether it's an oral or a parenteral. So basically, some sources you will find that if in the antibiotic it is there O, R, then generally they are oral, and if it is T, generally it is a parenteral. Okay, we will see it by example later on also. So let's focus on the generations of the antibiotics of the cephalosporin. So we will touch the first generation. So among the oral, the first generation antibiotics among the oral, they are cephalexin, cefadroxil, and cephredine. Okay, I will repeat it again. Among the oral, we have got cephalexin, cefadroxil, and cephredine. Among the first generation only, in the parenteral, we have got cefazolin. So out of these cephalexin, cefadroxil, cephredine, and cefazolin, most clinically used antibiotic among the first generation is cefazolin. We will see where it is used when we will be talking about the clinical uses. Okay, so please remember, in the first generation, divided into 2 categories, oral and the parenteral. Among the oral, we have got cephalexin, cefadroxil, and cephredine, and among the parenteral, we have got cefazolin. Okay, just please try to remember the names. I know it's very difficult, but as you practice, you will be able to remember it. Coming to the second generation, among the second generation, we have got among the oral, we have got a cefaclor, cefuroxime exital, loracarbef, and cefprozil. Okay, I will repeat it again. Amongst the oral, we have got cefaclor, cefuroxime exital, loracarbef, and cefprozil. Okay, these are amongst the oral under the second generation. And in the parental, we have got cefuroxime, cefotetan, cefoxitin, and cefmetazole. Okay, so I will repeat it again. Under the second generation, among oral, we have got cefaclor, cefuroxime exital, loracarbef, and cefprozil. Okay. Under the same generation, among the parental, we have got cefuroxime, cefotetan, cefoxitin, and cefmetazole. Okay, let's try to remember the names. I know it's a little bit difficult for the first time you are hearing these names. Try to remember it. Then coming to the third generation, among the oral, we have got cefixime, cefodoxime, ceftibutane, ceftitorane, ceftinil, ceftamate pivoxit. Okay. One among the parental, we have got cefotaxime, ceftijoxime, ceftriaxone, ceftazidime, cefoperazone, and moxalactam. So these are the various antibiotics which have been categorized into the third generation. In the fourth generation, we don't have any oral antibiotic. We have got a parental one, and generally there are only two antibiotics which have been categorized in this group, fourth generation, among the parental form. These are cefepime and cefpirone. Cefepime and cefpirone. Okay. In the fifth generation also, we don't have any oral antibiotic as such. So there is only one group, that is a parental group. And in the parental group, we have ceftaroline fusimil and ceftobiprole medocaril. Okay, ceftaroline fusimil and ceftobiprole medocaril. If you can remember ceftaroline, well, good enough, and ceftobiprole will do. Okay, so the ceftaroline fusimil and ceftaroline medocaril, basically these are the products which once they are inside the body, they are metabolized into their active form, that is your ceftaroline and ceftobiprole. Okay. So once again, cephalosporins, they have been classified into the 5 generations. The first generation, depending upon their antibacterial spectrum. So how they differ in their antibacterial spectrum? If you can remember this much, that the first generation, they are active against your gram positive cocci. The second generation, they are active against your gram negative bacilli. Third generation, they are active against your gram positive cocci, gram negative cocci, then your gram negative bacilli, and even the anaerobic organism. Okay. The fourth generation, their antibacterial spectrum is same as of that of third generation. Okay, and plus only difference between the third generation and fourth generation is that in the fourth generation they are more resistant to the beta lactamases. Like your cefepime and cefpirone, they are more resistant to the beta lactamases in comparison to your third generation. Otherwise, their antibacterial spectrum is more or less same. Okay. Then fifth generation, also its antibacterial spectrum is same as of third generation. Okay, but it is having more of a gram negative activity, more comparison to the third generation. Okay. If you can remember this is good enough. In your books, if you read, you will get the name of different types of bacteria. You can remember that well and good. Okay. As for the practical purpose, for the classification point of view, you can remember this much, that first generation, they've got more activity against the gram positive cocci. So how it differs from the penicillin? So basically they are also active against the penicillin resistant gram positive cocci also in first generation. Okay. So so let's revise this again, because names are very important. Until you remember the names, you cannot go further ahead. So first generation divided into two categories, oral and parenteral, depending upon the route of administration. So among the oral, you have got cephalexin, cefotroxil and cefridine, and among the parenteral, you have got cefazolin. Okay, they are active against the gram-positive cocci. Example of gram-positive cocci like staphylococci and streptococci. Okay, the second generation amongst the oral, again divided into two categories, oral and parenteral. Among the oral, you have got cefaclor, cefroxime acetyl, loracarbef and cefprozil. Okay. Among the parenteral, under the second generation, you have got cefroxime, cefotitan, cefoxitin and cefmetazole. Okay, fair enough. And their antibacterial spectrum, they are active against your gram-negative bacilli like your E. coli and Klebsiella, Proteus, this microorganism. And among the third generation, they have, as per their antibacterial spectrum is concerned, they are active against your gram-positive cocci, that is your staphylococci and streptococci. Then gram-negative cocci like your monococcus. Then it is active against your gram-negative bacilli, as I told you, including the pseudomonas. And they are also active against the anaerobic organisms like the bacteroids. And among this third generation, among the oral category, you have got cefixime, cefotoxime, ceftibuten, ceftitorin, cefdinial and ceftamipivoxine. Okay. And among the parenteral, among the third generation, you have got cefotaxime, ceftriaxone, ceftriaxone, ceftazidime, cefoperazone, moxarlactone. Okay. Now fourth generation, as I told you, their antibacterial spectrum is more or less same as our third generation. So we have got, there is no oral category among the fourth generation. So we have got only parenteral category amongst the fourth generation. And in the parenteral category, we have cefepime and cefpirone. Okay. Same applicable for the fifth generation. So in the fifth generation, there is no oral category as such. We have got only parenteral category. And in the parenteral category, we have got two drugs, ceftaroline fusamine and ceftobiprole medocaine. Okay. Please remember these ceftaroline fusamine and ceftobiprole medocaine, these are the prodrugs. They are converted into the active form once they are inside the body. Okay. So this is as far as the classification of cephalosporin is concerned. Try to remember it, keep on reading again and again, and I am sure you will be able to remember this now. Okay, very simple to remember. 5 generations. First generation is your active against your gram-positive cocci, second generation against your gram-negative bacilli, third generation is got a very wider spectrum for gram-positive cocci, your gram-negative cocci, your gram-negative bacilli, even for the anaerobic organism. Okay, and fourth generation, what antibacterial spectrum is same as third generation. Okay, I hope that is clear till now. If you got any queries regarding this, once we have got once a regular class is started, you can always come and clarify your doubt. There's nothing actually. We have to just mug it up. We have to just remember the names. Okay. In some sources, you will find that how to remember whether these cephalosporin belongs to the first generation or second generation or third generation. Is there any mnemonic or is there any shortcut for that? You may find from some sources we find there are some mnemonics have been made, like how to identify that for which generation they belong. Like in the first generation, they say if antibiotic name is starting with Cef followed by A, so generally it belongs to your first generation, except this exception, except your cefaclor. Cefaclor, we said it belongs to the second generation, oral antibiotic. Okay. So like if I say cefadroxil, so CEFA, cef followed by a, cefadroxil. So we can say, or we can assume that it belongs to your first generation of cephalosporin. Other example, if you want to see, like among the parental, among the first generation you have got cefajolin, CEF followed by a, cefajolin. So generally belong to first generation. Then they say that if the name of the antibiotic contains, among the cephalosporins, antibiotic contain pi, PI. If there is a PI in the name, generally it belongs to your fourth generation. That is cefepime and cefpirome, CEF, PI. Cefepime and cefpirome. So generally they belong to fourth generation. So remember, we said there is no oral group in the fourth generation. There is only parental group. Okay. Now it is there is a if there is a role in the name in the cephalosporin antibiotic name, then generally it is said that it belongs to the fifth generation, like your ceftaroline, cefta, CEFTA, ROL. Okay, role, ROL. The ROL is present in the name of the antibiotic. We can say generally it is said that it belongs to your fifth generation. I am talking about whatever antibiotics are available till now. Okay, so like ceftaroline, ceftobiprole. So they are among the fifth generation. Okay. Now, so we have talked about the first generation, fourth generation, and fifth generation. The third generation, they say the name of the antibiotic name is ending with me 10 or 1, ME or ONE or TEN. So generally it belongs to your third generation cephalosporins. Okay. The name of the antibiotic is ending with, like take example of me. So if you can recollect, among the oral we have got the cefixime. So the word is ending with ME, cefixime. Okay, so generally we can say belongs to third generation, or cefodoxime or cefotaxime, okay. Now with me, then I said ONE, then like example like ceftriaxone, cefoperazone, okay, or I said ending with TEN, like ceftibutane, ceftitorane. Okay, these are belongs to your third generation. There's some exceptions again, like if it is cefroxime, though it is ending with ME, but it belongs to your second generation of your cephalosporins. Rest all cephalosporins, you can say it is not fulfilling all these things, you can say they belongs to your second generation cephalosporins. There are some exceptions, except your ceftinid and your moxalactam, they belongs to your third generation. Okay. So various mnemonics or shortcuts you will find it from various sources. I've just covered so that you are aware of that these things are there, but these things are not there in any of the standard textbooks. Okay. So the best thing is, if you can remember the names of the cephalosporins generation wise, it will be of more help to you instead of going for the shortcuts and all this thing. Okay. So please try to remember the names of these cephalosporins. Okay. So we will revise it again and again and again so that these names get imprinted in your mind. So coming to the antibacterial spectrum, I think we have already covered it, but let's revise it again. So among the first generation, I told you that they are mostly active against your gram-positive cocci, okay, like your staphylococci and streptococci. Your second generation, they are more active against your gram-negative bacilli. They also have a some gram-positive activity also, but they are more active against your gram-negative bacilli, like your E. coli, Klebsiella, Proteus, Haemophilus influenza, bacteroids. Okay. The only thing I said bacteroids. So here what you need to remember is that all the cephalosporins which come under second generation, they are not active against your bacteroids. Only your cefoxetine, cefotitan, and cefmetrazole. Okay, only three of them, cefoxitin, cefotetan and cefmetazole. They are effective against your Bacteroides facilis. Okay, cefoxitin, cefotetan and cefmetazole, they are only effective against your Bacteroides facilis. Please remember, okay, cefoxitin, cefotetan and cefmetazole, they are only among the second generation cephalosporin, they are only effective against your Bacteroides facilis. Okay. In third generation, we have seen that they are active against your gram-positive cocci, also your gram-negative cocci like your gonococcus. And they are active against your gram-negative bacilli, that is your Enterobacteriaceae, Serratia and Pseudomonas. And they are active against your bacteroids and your anaerobes. Okay, so basically it has got a extended gram-negative activity. Okay. Fourth, we have said that their anti-spectrum activity is same as your third generation, except that it doesn't have any activity against the anaerobes. Okay, and fifth generations, they are generally effective against your methylene resistant staph aureus. Okay, MRS, only the fifth generation they are. Okay, so I know it's a little bit of confusing, but you have to remember it. The first generation, I'm repeating again and again so that you have a basic idea about what is the antibacterial spectrum of these different generations of cephalosporins. Okay. So first generation, it's revises again this last time. First generation, gram-positive cocci. Second generation, your gram-negative bacilli. Okay. Among the second generation, the important thing which you have to remember is that only cefoxitin, cefotetan and cefmetazole, they are effective against your Bacteroides facilis. Okay. The third generation, they have got a wider antibacterial spectrum, like they are active against your gram-positive cocci, that is your staph and strepto. Then your gram-negative cocci, like your gonococci, the gonococcus causes gonorrhea. So one of the antibiotics from the third generation is used for the treatment of gonorrhea. We will see in the clinical uses. Then gram-negative bacilli, we have got Enterobacteriaceae, Serratia and Pseudomonas, and among the anaerobes we have got bacteroids. So third have got a very wide antibacterial spectrum. Okay. In the fourth generation, the antibacterial spectrum is same as the third generation, except that they are not active against the anaerobes. Okay. So here, why it is important to remember this? Suppose we are using a fourth generation antibiotic, cephalosporins, and we suspect that there may be some anaerobic infection also. So along with this fourth generation, we have to use some antibiotic against the anaerobes like the metronidazole or something. Okay, that's why it's very important to remember the antibacterial spectrum. Okay, and as for the fifth generation are concerned, you just remember that they are effective against your MRS. And if I ask you the name, what are the two drugs in the fifth generation? So we have got ceftaroline and ceftadiploid. Okay, so they are active against your MRSA, methylene resistant staph aureus. So this is as far as the antibacterial spectrum is concerned. Okay, you are with me till now? So till now what we have covered? We have covered cephalosporin, they belongs to your beta-lactam group of antibiotics. How they act? They act by inhibiting the cell wall peptide glycan synthesis by inhibiting the enzyme transcriptase. Then we have seen the different classes of your cephalosporins, how they have been classified. So they have been classified into 5 generations, and they have been each generation have been further classified into the oral and parenteral depending upon the route of administration. Okay. So your fourth and fifth generation, it has got only the parenteral forms. There is no oral category in that. Okay. And we have seen the antibacterial spectrum of each generation, because the basis of classification was the antibacterial spectrum. Okay. So first generation, they are more active against your gram-positive cocci like your staphylococcus and streptococcus. Your second generation, more active against your gram-negative bacilli. It also has got some gram-positive activity against the gram-positive activity, but mostly on the gram-negative bacilli like your E. coli, Klebsiella, Proteus, Haemophilus influenza, and bacteroids also. So as far as the bacteroids are concerned, only the 3 Antibiotic comes the second generation, that is your cefoxitin, cefotitan and cefmetozole. They are effective against your bacteroides flagellae. Okay. The third generation antibacterial spectrum, we have seen that it is a very wide, like it is effective against your gram-positive cocci also, your gram-negative cocci like your gonococcus, your gram-negative bacilli like your Enterobacteriaceae, Serratia, Pseudomonas, and even against the anaerobes like bacteroids. Okay. So it has got a very wide antibacterial spectrum. The fourth generation, the antibacterial spectrum is same as of third generation, that is they are effective against your gram-positive cocci, your gram-negative cocci, your gram-negative bacilli, except that it doesn't have any activity against the anaerobes. So when you are suspecting, when you are in clinical practice, when you are suspecting that a particular type of infection which you are treating may contains the anaerobic infection, in that case you have to use antibiotic against the anaerobic organism whenever you are using the fourth generation. At this fourth generation, like your CPP and CPP-ROM, it doesn't have any activity against the anaerobes. Okay, they are more resistant to beta-lactamases. Your fifth generation antibiotics, basically they are, just remember that they are effective against your MRSA. Now if I ask you, suppose if I ask you, okay, do you know any organism, microorganism against which these cephalosporins are not active at all? Okay, so earlier we used to say they are not active against the MRSA, but now we have got a fifth generation cephalosporins which are active against the MRSA also. But your like organism like your Listeria monocytogenes, no cephalosporins is active against your Listeria monocytogenes. There are some more in different books, you will find different names, but most important, very important is this fact that Listeria monocytogenes, no cephalosporins are active against Listeria monocytogenes. Okay, so we will proceed further ahead. After the mechanism of action, after the classification, now let's come to the pharmacokinetic part. Okay. So we will see, we will touch on the only important pharmacokinetic part and what can be the possible clinical implications of that important pharmacokinetic part. Okay. So as we know, in the pharmacokinetic we have got AD, MD, absorption, distribution, metabolism and excretion. So absorption, basically most of the they are readily absorbed after the oral administration. So whatever oral antibiotics we have got, they are readily absorbed after the oral administration. Now as for the distribution is concerned, there are two very important points, like ceftriaxone. You remember ceftriaxone? It comes under your third generation cephalosporins among your parental. Okay. So it has got a very high affinity binding for serum albumin. It may displace bilirubin, causing jaundice in neonates. Okay. So ceftriaxone, it has got a very high affinity binding for serum bilirubin. So it may displace bilirubin, causing jaundice in neonates. So that's why the ceftriaxone is avoided in neonates. And which cephalosporin is preferred? Then cefotaxime is preferred in neonates. Suppose you have to use cephalosporin, third generation cephalosporin for treating some infection in neonates. So we will avoid ceftriaxone. Reason I already told you, because it has got a high affinity binding for your serum albumin, so it will displace the bilirubin and it can lead to jaundice in the neonates. Okay, so we will not prefer ceftriaxone. Which is preferred in neonates? It is your cefotaxime. Okay, cefotaxime, it is preferred in neonates. Ceftriaxone is not preferred because it may displace the bilirubin, causing jaundice in the neonates. Okay. Then second important point is your cefoperazone and cefixime. Okay. The cefoperazone and cefixime, they cannot cross the blood-brain barrier. Okay. So if something cannot cross the blood-brain barrier, it will not be effective against the. It cannot be used basically for the treatment of infection which is inside the blood-brain barrier. For example, take example of meningitis. Okay, so this cefoperazone and cefixime, since they cannot cross the blood-brain barrier, so they should not be used for the management of or in the treatment of your meningitis. So two important points as far as the distribution is concerned, which I told you that ceftriaxone, it has got a very high affinity for the serum albumin, so it may displace the bilirubin, causing jaundice in the neonate. So we will avoid ceftriaxone in the neonates, and instead of ceftriaxone, what is preferred in neonate is a cefotaxime. Okay, so no ceftriaxone in the neonates. If we have to use a third generation cephalosporin, cefotaxime is preferred in neonates. Okay. Second important point in the distribution, which I told you that cefoperazone and cefixime, they cannot cross the blood-brain barrier. Okay, they cannot cross the blood-brain barrier, so they should not be used for the treatment of meningitis. Okay. Cefoperazone and cefixime. Please remember. Cefixime is which generation? Please tell me. Cefixime, we said it is an oral. It's an oral formulation, third generation, and your cefoperazone, your parental formulation, your parental form, third generation. Okay. Now, as far as the metabolism is concerned, so we have seen the absorption, distribution, and metabolism. So as far as the metabolism is concerned, your cefotaxime is metabolized into the active metabolite des-acetyl cefotaxime. Please remember this. Your cefotaxime, it gets metabolized into an active metabolite called as des-acetyl cefotaxime. Just remember this. Okay. Coming to the excretion part, now very important as far as the excretion is concerned. Now most of these cephalosporins, they are excreted by kidney through tubular secretion. Through tubular secretion they are excreted. So there are two clinical implications, except there are two drugs like your cefoperazone, they are excreted through your bile, and your ceftriaxone, partly they excreted in the bile and partly through your kidney. Okay. Excretion, as far as excretion is concerned, most of these drugs are excreted by kidney by tubular secretion, except your cefoperazone, which is excreted in the bile, and your ceftriaxone, partly of which are excreted in bile and partly through your kidney. Okay. Understood? Please remember this. Excretion, most are excreted by kidney through tubular secretion, except cefoperazone, which are excreted in the bile, and ceftriaxone, which are partly excreted in the bile and partly through your kidney. So what are the implications, clinical implications of what I said? Take example, suppose a patient is there which has got an impaired renal function. So we may have to reduce the dose of the cephalosporins in a patient who has got an impaired renal disease, except cefoperazone, which are, I told you, which are excreted in your bile. So cefoperazone can be there is no requirement of dose reduction for cefoperazone, and ceftriaxone, since partly it is treated through bile and partly through kidney, so dose reduction may be little bit less as far as the ceftriaxone is concerned. Okay. Second clinical implication, you can say, I said that most of these drugs are excreted through tubular secretion. Okay. So do you know any drug which can inhibit the tubular secretion? I think if you can remember, we must have heard about the probenecid. Okay, so suppose some patient is taking probenecid also, or so probenecid will inhibit the tubular secretion, so it will increase the activity or increase the duration of activity of this cephalosporin, which can lead to toxicity also. Okay, so these are the two important things. Other important thing is that I told you cefoperazone, they are excreted through bile. Okay. And ceftriaxone also partly through bile and partly through kidney. Okay. So what is the clinical implication of that? Now cephos, basically as far as the side effect is concerned, like diarrhea. Okay. So diarrhea is more seen with cefoperazone due to the high biliary excretion. Okay. So diarrhea is one of the very common adverse effect of your cefoperazone, because it is because of the high biliary excretion. Okay. And it can also cause pseudo polylithiasis. And ceftriaxone also, it is partly excreted through your bile, I told you. And plus, one more important property of ceftriaxone is that it has got a very high affinity for calcium. Okay, so because of these two, the ceftriaxone can also cause biliary pseudolithiasis. Okay, so cefoperazone and ceftriaxone, they can cause biliary pseudolithiasis. Is that clear? Okay, so we'll just quickly revise on the pharmacokinetics was an important thing. Absorption, I said most of the oral cephalus which are given, they are readily absorbed after oral administration. As far as the distribution is concerned, we have discussed two important points. One was regarding the neonates, like ceftriaxone. It has got a very high affinity for your serum albumin. So what it can do, it can displace the bilirubin, causing jaundice in neonates. So we will not use ceftriaxone, or we will avoid ceftriaxone in neonates. Instead of ceftriaxone, which is preferred cephalosporin in neonates, is a cefotaxime among the third generation. Second important point which we discussed about utilization was your blood-brain barrier. So your cefoperazone and cefixime, they cannot cross the blood-brain barrier, so they should not be used in the management of meningitis. Okay. Metabolism, we say only one point, that cefotaxime, they are metabolized into the active metabolite, that is acetyl cefotaxime. Please remember that. As far as the excretion is concerned, most are excreted by kidney through tubular secretion. So we have got, except for two drugs we told, that cefoperazone, they are exclusively excreted from the bile, and ceftriaxone, they are partly excreted to the bile and partly to the kidney. Okay. So what are the implications as far as the excretion points are concerned? That we may have to reduce the dose of cephalosporins in the patient who has got an impaired renal function, except for your cefoperazone, which is exclusively excreted to your bile, and ceftriaxone, which is partly excreted to your bile. The dose duration may be less. Okay. Second, very important point, we said if drugs like probenecid, which inhibits the tubular secretion, it may increase the duration of action of the cephalosporins, which may lead to toxicity. Other important point we have seen about as far as excretion is concerned, that it can cause biliary pseudolithiasis, both cefoperazone and your ceftriaxone. Ceftriaxone, one additional point was that it has got a high affinity for calcium, so it can precipitate in the biliary. Okay, so it can cause the biliary pseudolithiasis. So this is as far as the pharmacokinetic is concerned, the important points related to the pharmacokinetic. Okay. So let's talk about the adverse reaction first before we go into the clinical uses. Okay. Now, adverse reaction, very important. One is the hypersensitivity reaction. Okay. As we know that the penicillin, the hypersensitivity reactions are seen with penicillin. Okay. The same is applicable to your cephalosporins. Now, cephalosporins, hypersensitivity reactions may come in the form of rash or fever or angioedema or breathlessness. So it can vary from mild to severe, okay, just like penicillin. Okay. Now, important thing about the hypersensitivity reaction, what are the clinical implications of this there? Suppose the patient has shown a hypersensitivity reaction to penicillin. Okay. So if I ask you, can we give cephalosporins to these kind of patients? So there is something called as cross sensitivity. Okay. Now cross sensitivity generally between the penicillin and cephalosporin, generally it is seen, some books say it is 1%, some say 4 to 5%, some say 5 to 10%. So please remember that this cross sensitivity between the penicillin and cephalosporin is there, which can vary from maybe 2% to 10%. Okay. And so if I ask you whether you will give cephalosporin to these patients, now generally what is said that if a patient has shown a hypersensitivity reaction to a penicillin, so generally we should avoid the first generation and second generation cephalosporins. Okay. And Generally we should avoid all the cephalosporins, but strictly first generation, second generation cephalosporin is to be avoided, and third generation and fourth generation and fifth generation cephalosporins can be given if needs to be given, but it is to be given under supervision, under the monitoring, wherever the monitoring facility is available. Okay. Okay. So this is as far as the hypersensitivity reactions are concerned, and I'm sure you all are aware of how to manage a hypersensitivity reaction. Anaphylaxis and all those things. Management, I'm sure you must be aware of. Okay. So one should know the management of anaphylaxis because it's a life-threatening emergency. So first adverse effect, your hypersensitivity reaction. Second adverse effect, your local reactions. Like suppose somebody has been given intramuscular, among the parental cephalosporins have been given by the intramuscular route, so it can cause pain. Somebody has been something has been given by IV route, so it can cause thrombophlebitis. Okay, so hypersensitivity reaction, local reactions. Third, like there are some drugs which contains a methyl thiotetrazole group. So drugs containing your methyl thiotetrazole group, like your cifamandole, your cifoperazone, your moxalactam, and cifotitan. Okay, cifamandole, cifoperazone, moxalactam, and cifotitan. These four drugs are very important because they are two important adverse effects which has been linked to it. One is that they can cause disulfiram-like reactions with alcohol. So we have to, if the patient is using these drugs, we have to tell to the patient that we have to avoid alcohol or any alcohol containing drugs. Okay, they have to avoid whenever the patient are using cifamandole, cifoperazone, moxalactam, and cifotitan. Okay, so disulfiram-like reaction with alcohol can occur. Now, second adverse effect which can occur with these four drugs are that it can prolong the prothrombin time. Okay, and it can leads to bleeding. Okay, so it can cause hypoprothrombinemia and leading to bleeding among the patient who are receiving anticoagulation or among the patient who has got vitamin K deficiency. So it can be managed by giving vitamin K 5 mg twice a day for 6-7 days. It can be managed. Okay. So two important reactions: drugs containing methyl thiotetrazole group like cifamandole, cifoperazone, moxalactam, and cifotitan. They can cause disulfiram-like reaction, or they can cause hypoproteinemia, leading to bleeding tendencies, especially among the patient who are on any other anticoagulants or who are vitamin K deficient. Now, ceftazidime, they are known to cause neutropenia. Ceftazidime. Then we have got cefepime. Some encephalopathy and non-convulsive status epilepticus has been reported with cefepime. Okay, so these are some of the important pseudolithiasis. Already told you pseudolysis with your cifoperazone and ceftriaxone. These are the important adverse reactions. Now, as far as the therapeutic uses are concerned, so the first generation you have got skin and soft tissue infections. They can be used for your skin and soft tissue infections. Your first generation, as they are mostly effective against your gram-positive cocci. Okay, so the drug which can be used mostly in the clinical practice is your cefazolin among the first generation, your parental form. These are the preferred for your perioperative surgical prophylaxis. Okay, cefazolin, drug of choice for surgical prophylaxis. Okay, the second generation generally used for your upper respiratory tract infections like your sinusitis and otitis media, which generally caused by your gram-negative bacilli. Okay, like ciprofloxacin, acetyl, oral form. Second important use is your perioperative prophylaxis in intra-abdominal and gynecological surgeries, where your cefoxitin and cifotitan are used, which are also active against your bacteroids if you remember. Okay. As far as the third generation are concerned, they have got a multiple uses of the third generation. So third generation cephalosporins are basically more clinically used because they have got a wider spectrum of activity, antibacterial activity. Okay. So like they are used for community-acquired pneumonia, meningitis, urinary tract infections, your septicococcal endocarditis. Ceftriaxone is used in gonorrhea, typhoid. So please remember that for gonorrhea, ceftriaxone is used for the management of typhoid. Ceftriaxone can be given. Okay, because I told you that third generations are also affecting your gram-negative cocci like your gonococcus also. Okay. Then fourth generation, basically they are used for nosocomial infection caused by pseudomonas, like your pneumonia, meningitis, UTI. And fifth generation, we have already seen they are anti-MRSA. They can be used against the MRSA infection. Okay. So coming to therapeutic uses, sometimes as far as exams are concerned, sometimes you are asked to write a prophylaxis or your prescription, like suppose for surgical prophylaxis. So you have to remember the doses of some of these drugs, like your cefazolin. They can be used 1 gram 30 minutes before surgery, and ceftriaxone, like for gonorrhea and chancroid, they can be given 1 gram IM single dose. Okay. For enteric fever or typhoid, they can be given 4 gram IV daily for 2 days, followed by 2 gram per day till 2 days after fever subsides. So some of the doses of some of these drugs you have to remember, okay, because you may be asked to write a prescription on this. Okay, so that's all we have covered. I think we have seen the cephalosporins, so we have seen their mechanism of action, we have seen their classification, we have seen its antibacterial spectrum, we have seen some of the important points in the pharmacokinetics, we have seen the adverse effect, we have seen the therapeutic uses of the cephalosporins. Okay, so that's all. If any queries there, you can ask once the regular classes is started. In the meantime, keep yourself safe and keep all the necessary precautions as far as the COVID-19 infection is concerned. Okay, thank you so much. Thank you.
सर आप उसमें वो साइन कर दीजिए और डिपार्टमेंट का नाम
Good morning.
एक सेकंड सर
Good morning.
एक सेकंड आवाज अब आएगा सर चल तो रहा है सर ये
थोड़ा
चलता रहे।
देखो अभी मैं ये किया था मैंने, फुल स्क्रीन पे आ गया, देखो ये भी आ गया। एक बार उसे बंद करके दोबारा चलाओ सर। सर चल तो रहा है सर ये।
हाँ
चल आ जाओ।
ठीक है।
So I'll start.
बोलो।
Okay. Good morning, students. So today we have a couple of lectures and seminars, and we'll start with the first class, which is acute leukemia. So in this class we will learn about the different aspects of acute leukemia, including the cell of origin, the types of acute leukemia, the different modalities of investigations which are used in the diagnosis and prognosis of acute leukemias, and in the end we will touch about briefly about the treatment modalities. So what is acute leukemia and how does it arise? So for this we need to understand the normal hematopoiesis. So we know the blood cells are composed of red blood cells, white blood cells and platelets, and all this arises from a specific progenitor cell, and which in turn arises from a hematopoietic stem cell. So acute leukemias arises from the progenitor cell. We know there are two major types of progenitor cells: lymphoid progenitor cell and myeloid progenitor cell. The leukemia arising from a lymphoid progenitor cell gives rise to an acute lymphoblastic leukemia, and the acute leukemia arising from a myeloid progenitor cell gives rise to an acute myeloid leukemia. Rarely it can arise earlier in the stem cell, then it gives rise to an acute undifferentiated leukemia. So as you can see, in acute leukemia the two major types or the two broad categories are ALL, which is acute lymphoblastic leukemia, and AML, which is acute myeloid leukemia. On the right side of the picture you can see more mature cells, which can be lymphocytes or other lineage cells. Neoplasms can arise from these cells, but they give rise to different types of hematopoietic tumors. So in this class we will learn about acute lymphoblastic leukemia and acute myeloid leukemia, and in each category we will learn the different aspects of these diseases, which include a brief introduction, classification and pathogenesis, diagnosis using morphology, flow cytometry, cytogenetic studies and fish studies, molecular genetic studies, and at the end we will briefly touch upon treatment modalities. So leukemia, as we just saw, is a malignant disease characterized by unregulated proliferation of one cell type. So this involves any of the cell lines or a stem cell which is common to several cell lines. So any of the cell line meaning lymphoid progenitor or a myeloid progenitor cell in the case of acute leukemias. So broadly, leukemias we can classify into two major categories, chronic and acute. The behavior and the cell of origin is slightly different. In chronic leukemias, the onset is slower, whereas in comparison in acute leukemias, the onset of the disease is rapid, and the disease is less aggressive in the case of chronic leukemias, whereas it is much more aggressive in the case of acute leukemias. And in the case of chronic leukemias, the cells involved are usually more mature cells, whereas in the case of acute leukemias, the cell of origin is a blast, which is a earlier hematopoietic cell, which is a less differentiated cell. It is a malignant transformation of a stem cell leading on to an unregulated proliferation, and it's not just the proliferation but arrest, meaning
that is stop in maturation at the earlier stage, so that the cell differentiate into a mature cell. So blast is the most immature cell that is known to committed to a particular cell lineage. So in the case of acute leukemia, the cell of origin is a blast which is committed to a particular lineage, either lymphoid or myeloid, leading out to a acute lymphoblastic leukemia or a acute myeloid leukemia. ALL and AML behave slightly differently, but there are many common clinical features in both the categories of acute leukemia. This include leukemic proliferation of the cells, accumulation of the cells, and invasion of normal tissues. The most commonly involved organ systems or organs are the lymphoreticular system, which include the liver, spleen, lymph nodes, and the bone marrow, which is usually the site of origin of the disease. The other systems which have predilection for invasion of these blasts are central nervous system. It can involve the skin, and it can involve few other organ systems also, which we will see subsequently. And it's not just the invasion of these tissues, but there is lack of differentiation, leading to accumulation of cells in the earlier blast stage. So coming to the etiology, what causes acute leukemia? The exact cause or a single known factor has not been found, but various factors have been proposed. This include both the host factors, which means factors in the particular individual who develops acute leukemia, or environmental or extrinsic factors which are independent of the person involved. So when we look at the host factors, many persons have an increased inherited predisposition and chromosomal fragility or abnormalities. This could be abnormal chromosomal breakage syndromes, or syndromes associated with abnormal chromosome numbers, for example trisomies like Down syndrome. There can be hereditary immunodeficiencies, different types of immunodeficiencies in which there is irregular immune regulation, leading on to loss in the checks in the normal differentiation, leading on to acute leukemias. Other hematopoietic disorders like myeloproliferative diseases and myelodysplastic syndromes can evolve or later lead on to acute leukemic stage. Bone marrow failure syndromes are dysfunction of a bone marrow, including aplastic anemias and paroxysmal nocturnal hemoglobinurias, can also lead on to acute leukemias in the later stages especially. So these are the factors which are intrinsic to the so there are other factors which are extrinsic so there are certain extrinsic factors or environmental factors which are independent of the particular individual. This includes the exposure to ionizing radiation, exposure to mutagenic chemicals and drugs. This could be a variety of chemicals including benzene and certain viral infections. So coming to the general pathogenesis or the overall pathogenesis of acute leukemias. So most of these acute leukemias have in common abnormalities in the chromosomes or genes. And what are the normal functions of these chromosomes or genes? They usually regulate the expression and function of transcription factors and are involved in the differentiation of normal T, B and myeloid cells. So in acute leukemias, especially in ALLs, many chromosomal aberrations occur which dysregulate the expression and function of transcription factors that are normally required for differentiation. So when there is a defect in the differentiation, the normal differentiation of cells, that leads on to acute leukemias. For example, in T acute lymphoblastic leukemias, 70% of the cases have gain of function mutations in Notch1. So what is Notch1? Notch1 is a gene which is normally essential for T cell differentiation, meaning maturation of the T cells. So in T ALLs, there is abnormality in this Notch1 gene, which is associated with development of T acute lymphoblastic leukemias. BALs have a variety of mutations in the genes and chromosomal abnormalities, many of which are involved in normal B cell differentiation. Whereas in the case of B acute lymphoblastic leukemias, there is loss of mutation in these genes that are required for B cell differentiation, and these include, for example, PAX5 gene, which is normally required for B cell differentiation. So mutation in this gene lead on to B acute lymphoblastic leukemia. So to mention, these are a few mutations, but there are different other chromosomal and genetic abnormalities. This varied chromosomal abnormalities and mutations, they promote maturation arrest and increase self-renewal, and these are considered as hallmarks of hematopoietic cancers. 90% of all ALLs have some chromosomal abnormalities. In BALLs, commonly we see numerical abnormalities, meaning the chromosome numbers are altered. So normally we have 46 chromosomes. So the number of chromosomes can increase or decrease due to gain of a few chromosomes or loss of a few chromosomes. Hyperdiploidy is a commonly seen feature, meaning increased number of chromosomes than what is normally seen in a diploid cell, and several other translocations. Classical one is a 12, 20, 21 translocation. There is translocation between chromosome 12 and 21, and this involves fusion of genes ETV6 and RANX1, leading on to aberrant transcription factors or abnormal proteins. So this abnormality is common in childhood BALL, whereas in adult BALLs, a common chromosomal abnormality is translocation of chromosomes 9 and 22 involving the BCR-ABL genes. So you all must be aware that in chronic myeloid leukemia, translocation 922 is the most pathogenic chromosomal abnormality. A similar but slightly different abnormality is also seen in adult pre-B ALLs. So what about TALLs? So in TALLs, the mutations are commonly involved in the T cell receptor locus and certain transcription factors involved in T cell differentiation. And mutations also inactivate tumor suppressor genes such as PTEN and CDKN2A, which regulate the function of P53 gene or protein. So most of the B and T ALLs have some karyotypic abnormalities and genetic abnormalities in common, which involve few genes which are key factors in the differentiation or maturation of function of different cells, and abnormalities in these underlie the development of acute leukemias, both B and T. So what are the clinical features? How do these acute leukemias present? So an acute leukemia is characterized by increased proliferation of blasts in the bone marrow. So what happens when there is increased proliferation of blasts in the bone marrow? The normal hematopoietic cells are suppressed or reduced in number. So when the normal hematopoietic cells are suppressed or reduced, that leads on to reduction in the number of normal red blood cells, and symptoms arises because of the reduced number of normal blood cells. That could be symptoms arising because of reduced hemoglobin or reduced red blood cells, which is basically fatigue, which results from anemia. Reduction in white blood cells, especially neutrophils, leads on to neutropenia, and this puts the individual at risk of infections, and many times the patients present with fever. There is reduction of megakaryocytes in the bone marrow because of proliferation of blasts. This leads on to reduced production of platelets, so thrombocytopenia. This results in bleeding. So the patient can present with one or two or all three symptoms of this cytopenias, fatigue, fever, and or bleeding. And when the cells proliferate, they form a bulk or mass effect, which leads on to infiltration in different organs. So the symptoms are because of infiltration or proliferation of these blasts in different organs in the body. As we just saw, the main organ of proliferation is bone marrow. So when the bone marrow proliferates, it doesn't have much space, so it tries to expand the bone marrow and fill up all the bone. This causes stretching of the bone spaces and stretching of the periosteum, which leads on to bone pain. So it's not uncommon for patients to have generalized body pain or bone pain because of this bone marrow expansion. And all these blood cells have predilection for lymphoreticular system, which includes lymphadenopathy or lymph node enlargement, which is usually generalized, and involvement of liver and spleen, and enlargement of these organs because of infiltration, which leads on to hepatomegaly or splenomegaly, and many times both. TALL has a particular predilection to present as a mediastinal mass, what we call a lymphoblastic lymphoma. So when there is this mass present in the mediastinum, it leads on to Moss effects, especially compression of large blood vessels in the thorax, leading on to what we call as vena cava syndromes, especially in the upper limbs and in the face, leading on to engorgement of blood vessels. And many times, because of the mass effect, the trachea is compressed, leading on to breathing difficulties and manifestations of hypoxia. So when an individual presents with a mediastinal mass, lymphoblastic lymphoma, which is basically genetically and immunophenotypically similar to T acute lymphoblastic leukemia, is an important definition. Many of these acute leukemias have a predilection to invade the central nervous system, which is usually in the form of meningeal spread, but can also involve the ventricles and the parenchyma. Then this leads on to specific manifestations of CNS involvement, including headache, vomiting, and nerve palsies, etc. ALLs have a predilection to also involve testis in males. That's the importance of examining the testis in the case of children diagnosed with acute lymphoblastic leukemias. This happens especially during relapse. So these are all the clinical features which are mainly due to involvement of marrow and infiltration of different organ systems by the leukemic lymphoblasts or myeloblasts for that matter. So what do we see in the peripheral blood and bone marrow? So this is hematopoietic tumor. So this manifests as mainly as abnormalities in the peripheral blood and bone marrow. We saw the clinical features which arise because of involvement of peripheral blood, which is anemia because of reduced red blood cell production, reduced platelets because of reduced monokaryocytes. The WBC count can be variable. Many times the WBC count is high, what we call a leukemic presentation, because of increased proliferation of blasts in the bone marrow. Many of the blasts are thrown out or sent out into the peripheral blood, leading on to increased WBC. This can be anywhere from thousands to occasionally lakhs. So when the count is in lakhs, then it leads on to hyperleukocytosis and the stasis syndromes. Rarely it can be aleukemic, in the sense there is reduced number of WBCs, and many times we are not fortunate enough to see blasts in the peripheral blood. This is because the bone marrow is so packed that none of the cells are released into the peripheral blood, but at the same time there is reduced normal hematopoiesis, so there is reduction in the normal WBCs as well. Sometimes we have subleukemic presentation, where the WBC is normal, but you can still see a few blasts in the peripheral blood. The bone marrow is typically hypercellular, meaning there is increase in the bone marrow cellularity. So normally we see in a bone marrow hematopoietic cells as well as a few fat particles. So when the bone marrow becomes hypercellular, especially in cases like acute leukemia, there is loss of this fat spaces, and the blood component, the blood cell component is increased. In the case of acute leukemias, the hypercellularity or increase in cellularity is because of increased number of blasts. So when the blasts are increased, what do? They reduce the normal hematopoietic cells. So what are the normal hematopoietic cells? Normally in the bone marrow we see erythroid precursors or erythroblasts. We see myeloid series of cells. You see promyelocytes, myelocytes, metamyelocytes, granulocytes. The normal cells are very much reduced. You also see a fair number of megakaryocytes in a normal marrow, whereas in case of acute leukemia, the megakaryocyte numbers are also reduced. So the bone marrow is typically hypercellular, increased cellularity, which is mainly due to increase in the blasts and reduction in the normal hematopoietic cells. And so the blasts are increased, but what is the number needed to define an acute leukemia? So the number of blasts should be 20% or more, either in the peripheral blood or bone marrow. Many times we see increased blasts in both peripheral blood and bone marrow. So 20% is the cutoff which we use to define an acute leukemia. So there are array of investigations which we do when we suspect an acute leukemia. This starts from simple investigations to very complex studies. A complete blood count is a commonly used investigation which points out many abnormalities in the blood counts, and good peripheral smear examination shows us the morphology of the blasts if they are present in the peripheral blood. A bone marrow examination is a key examination, a key test in the case of an acute leukemia. So when we sample the bone marrow, we sample both the aspirate, which is a liquid sample, and we take a small piece of bone called the bone marrow biopsy. The bone marrow aspirate is typically used for other special investigations, which include cytochemical studies, flow cytometry, and genetic evaluation, which could be evaluation of the chromosomes, the chromosome number and structure. This is called cytogenetic study. Or we can look at the genetic changes or the changes in the DNA structure, what we call as molecular genetic studies. So in a given patient, we do almost all or most of the investigations to diagnose acute leukemia, to subtype an acute leukemia, and many times we use these studies for prognostication or risk stratification of these cases. Nowadays we use a few of these tests to assess the response to treatment as well. So there are two main types of acute leukemia. One is acute myeloid leukemia, which arises from a myeloid cell line, and there are different types depending on what stage is involved. It could be myeloblastic, promyelocytic, monocytic, or erythroid and megakaryocytic. And a second one is acute lymphoblastic, which could be either B or T ALLs. In general, ALLs are more common in children and AML in adults, but this is a gross oversimplification. AMLs can also occur in children, and vice versa, ALLs can also occur in adults. And acute leukemia can occur in all age groups, but there is a small bimodal distribution. It's more commoner in young children and elderly individuals. So extremes of age, this acute leukemia is seen different subtypes. So we'll go into a little bit in detail about the morphology and other features of acute lymphoblastic leukemia. So when we say ALL, we include both B and T ALL. By and large, BALL is the commoner one of the two, which accounts for about 85% of the cases, and the rest 15% are because of TALL. So the important cell in ALL is a blast. This is what we call a lymphoblast. Compared to a myeloblast, which is relatively smaller, and the cytoplasm is scant. In AMLs or in myeloblast, we see usually moderate to abundant cytoplasm. In ALL, the cytoplasm is scanty, meaning it is less in number. The chromatin is dense. The nucleoli is usually indistinct, and we don't see any R rods in the case of a lymphoblast. So we need to understand the B cell maturation to see what stage the B-ALL arises. So the progenitor cells themselves have different maturation stages before they mature onto mature lymphocyte. So depending on the stage of this progenitor cell, we can have early pro or pre B-ALLs. So the earlier classifications, the terminologies used were pro B, common B, pre B, and mature B ALL. So I want you to look at this table in the upper part, where you can see pro B, common B, pre B, and mature B based on different stages of the B lymphoblasts, and they are usually defined by the surface markers and the cytoplasmic markers present on these cells. For example, pro B is CD10 negative, whereas in common B the CD10 is positive, and the cytoplasmic immunoglobulin chains are negative in the earlier ones, whereas they start appearing in the later stages. And similarly, T-ALLs are also differentiated based on the stage of maturation of the T lymphoblasts. They can be pro, pre-T, cortical T, or mature T, depending on the presence of different cell surface markers. Common ones used are 7, 2, 5, 8, and CD1A for differentiation. So the Eagle classification was the earlier classification. The recent classifications and widely followed classifications are the WHO classification of hematopoietic tumors. So the WHO provides an extensive list of categories of all hematopoietic tumors, including acute leukemias. In acute leukemias, it provides different categories of acute lymphoblastic leukemias as well as acute myeloid leukemias. In ALLs, we have B-ALL and T-ALLs as broad category, and in this we also have different subcategories defined mainly by cytogenetic abnormalities and chromosomal translocations. So I'll just run you through the list of B-ALLs. So those with recurrent genetic abnormalities include B-ALL with translocation 922 or BCR-ABL1 fusion. As you all remember, this similar type of chromosomal abnormality is also seen in CML or chronic myeloid leukemia. Translocation with variant genes and 11q23, what we call a KMT2A rearranged one, and BALLs with translocation 1221, which is due to fusion of these two genes, ETV6 and RANX1, and BALLs with hyperdiploidy and hypodiploidy. So hyperdiploidy is the one in which the number of chromosomes is increased, and hypodiploidy is one in which the total number of chromosomes is less than diploid ones. Whereas in these three earlier ones, there is change in chromatin chromosome structure, but the number remains the same, that is 46 in total. And there are other subtypes, BALL with translocation 514 and BALL with translocation 119. There are a few provisional entities which is BALL, BCR, ABL1 like, and intrachromosomal amplification of chromosome 21. TALs are usually homogeneous except for a particular subtype, which is early T cell precursor lymphoblastic leukemia. So this is a one which has a relatively poorer prognosis in this TAL group. So how do we morphologically classify this BALs? So the earlier classification stressed on different morphological features to differentiate different subtypes of BALs. So the differentiation was called BALL, which is with L1 blasts, L2 blasts, and L3 blasts. So let us quickly go through each subtype of these blasts. So L1 blast is the one which is most commonly found in children, and it has the best prognosis. And here the cell size is small with fine clumped nuclear chromatin and absent or indistinct nucleoli. The nuclear shape is regular and with occasional clefting and indentations. The cytoplasm is scant with slight to moderate basophilia and variable vacuoles. So here you can see this L1 type of blast, which is clumped homogeneous chromatin. The nucleoli is usually absent, or if present, it is not very distinct. And as a rule, the lymphoblast have scant amount of cytoplasm. L2 is the second type of blasts, which is usually seen in adults. Here the cell size is little larger and with heterogeneous chromatin, and usually you can see a prominent nucleoli in most of the blasts. And the nucleus is irregular, you can see clefting and indentations. And the cytoplasm is variable, maybe a little more than what we see in the earlier case, and vacuoles are usually absent, but definitely less than ALL, L3. So what is L3? This is a rarer one. Here the cell size is large with homogeneous chromatin and the nucleoli is prominent. The nucleus is usually round to oval. The cytoplasm is abundant and you have many vacuoles in the cytoplasm. So this is an older classification. Now the most commonly followed classification is the WHO classification, in which you need to incorporate chromosomal and genetic abnormalities. So we move on to the second type of leukemias, acute leukemias, acute myeloid leukemias, which arise from myeloid progenitor cell. So similar to ALLs, we classify acute myeloid leukemia into different categories, and the classification takes into account different features. One, the morphology of this blast in the peripheral blood and bone marrow, the degree of cell maturation, or what stage this abnormality has occurred, whether it is myeloblast, monoblast, or promyelocyte, or megakaryoblast, etc. And we use different types of cytochemical stains to differentiate different types of acute leukemias. We will go through the different types of cytochemical stains in a bit. And we most commonly use flow cytometry for immunophenotyping, or to know the cell surface markers or the lineage markers in these blasts. Nowadays, a large amount of genetic information is needed for diagnosing specific subtypes, as well as classifying these acute leukemias. This includes both study of chromosomes called cytogenetics, as well as study of genes or molecular structures. We also need to know about the previous history of MDS, because we know MDS can lead on to acute myeloid leukemia, and this behaves in a poorer fashion, and the history of prior cytotoxic therapy. So prior cytotoxic therapy is also increased with, also associated with increased risk of development of AIIMS. So till recently, the most commonly used classification was the FAB classification, which is French American British classification. It is older classification but still holds good in present times because it is simpler and it takes into account mainly the morphology and cytochemistry of this blasts. So there are 7 different so the classification ranges from M0 to M7. We'll go through each of these categories in a bit. The recent classifications include WHO classification as similar to AIIMS. This classification is based on different information. So as we saw, there are recurrent genetic abnormalities in ALL. So similarly, we can have recurrent chromosomal abnormalities in AML as well. This includes mainly translocations, but also other genetic abnormalities like inversion. I will run you through some of the common types: AML with translocation 821, AML with translocation 1517, and AML with inversion 16. Second category is AML with multilineage dysplasia. As we just saw a few slides earlier, that an underlying MDS is associated with development of AML, which is called AML with multilineage dysplasia, or you can have AMLs without previous MDS, but still you can have dysplasias in the other cell lines in case of AMLs. Previous therapy, especially alkylating agents and epipodotoxin related AMLs can arise, which are usually associated with a poorer prognosis, and you have other subcategories. So if you look at the recurrent genetic abnormalities, there is a big list. We have seen a few commoner ones, and APL with PML RARA. So this is what we call acute promyelocytic leukemia, in which the important is the presence of abnormal promyelocytes, whereas in most other categories you see myeloblasts. You can have AML NOS which don't fit into any of the specific categories mentioned earlier. So this again has M0 to M7. Myelosarcoma is one in which the abnormal myeloid blasts are seen extramedullary, meaning outside the bone marrow. So this could be a mass lesion present in the skin or gums or anywhere else in the body except outside the bone marrow. So how does a myeloblast look like, and how does it differ from a lymphoblast? So again, it is a large cell and it has moderate to abundant amount of cytoplasm compared to a lymphoblast, and the cytoplasm has thin linear structures called OR rods. So here you can see this is a large cell, and it has abundant amount of cytoplasm, and you can see a thin linear structure or rod-like structure present within the cytoplasm, what we call a OR rod. So the presence of OR rod defines a myeloid lineage. So you can have AMLs with just presence of blasts, which constitute the M0 and M1 category, or you can have AMLs which has large amount of differentiated cells including granulocytes. So when you have a large maturer cells, it falls under the category of AML M2, but by definition you should have more than 20% myeloblasts in the peripheral blood and or bone marrow. AML M3 or acute promyelocytic leukemia is a specific category which needs to be recognized because of its distinct morphological features, its distinct clinical features, and as well as importance in specific therapy. So acute promyelocytic leukemia, AML M3, as the name suggests, is a leukemia which has large amount of promyelocytes. So what are promyelocytes? So normally promyelocytes can be seen in the bone marrow. So these are the next stage to myeloblasts. So when myeloblasts differentiate, they first differentiate onto promyelocyte. So this looks different from the blast in the sense that it has a lobe nucleus and granules. So in the case of acute promyelocytic leukemia, there is increase in this promyelocytes. So as you can see, there is a large amount of cells here with bilobed or angel wing like nucleus. So you can see one lobe here, and which are interconnected. So you can see a nucleus which has one lobe here, one lobe here. So there are two lobes which are connected, and in addition we have large amount of this R rods. So in the myeloblast which we saw earlier, it was having a single round nucleus with just one R rod, whereas in this case you can see multiple R rods, or what we call a fagot cell. So it is important to identify this subtype. It has a distinct characteristic feature, and the importance lies in the fact that many of these cases have increased tendency to bleed or increased risk of bleeding, especially into vital structures like the brain and CNS. So the importance lies in early identification and starting of a specific targeted therapy which is available for this particular subtype, which is ATRA and ATO, so all trans retinoic acid, which is a differentiating agents which differentiate these cells into mature cells, and arsenic trioxide. So there is a specific subcategory called hypogranular or microgranular acute promyelocytic leukemia, in which the nuclear morphology is similar in the sense that it is much convoluted and distended, but you don't see much granules in the cytoplasm. So you can have acute leukemias with monoblastic component. So M4 is one where you have both myeloblast as well as monoblasts. So when both of these are present, it is an AML M4 or acute monoblastic leukemia, and this one has predilection to involve the extramedullary sites commonly. M5 is a category which is predominantly composed of monoblastic or monocytic series of cells. When it is mainly monoblast, we call M5A, and if it is due to promonocytes mainly, then we call it as M5B. And M6 is the one in which there is predominance of erythroblast. So this is what we call an erythroleukemia. So monoblasts are slightly different in the sense they have large amount of cytoplasm. R rods are usually absent, and you can have very fine granules, but even blasts can be present without any granules. In promonocytes, you can see that these cells are convoluted or folded upon each other, like there are multiple small delicate foldings. So this can be confused with APML, but here you don't have granules or R rods which are characteristic of APML. M7 is the one where the lineage or the blasts are of the megakaryocytic lineage. So there is increased megakaryoblast proliferation and presence of atypical megakaryocytes. So these are the different morphological subtypes of AML. So what are the lab investigations we do? So first we start with cytochemistry. So cytochemistry is the one where special staining identifies the particular lineage. The commonly used staining is the myeloperoxidase staining. So myeloperoxidase is a primary granule found in late blast stage, which is characteristically positive in myeloblast, usually absent in monocytes, and almost always absent in lymphoblasts. So you can see a neutrophil which is positive. This brown color is positive, and a myeloblast also shows a positivity. Sudan plaque is another stain which stains the phospholipids and fats, and also it's present in the granulocytic cells, meaning myeloblast, granulocytes, myelocytes, metamyelocytes. So you can see this black dots within the cytoplasm of the cell, and it is positive in the myeloblasts. It's usually negative in lymphoblasts. Non-specific esterase is the one where it is positive in the monocytic cells. So it is used to identify monoblasts and promonocytes and even monocytes. As you can see, a monoblast which shows this brown granules in the cytoplasm, which indicates positivity. Acid phosphatase is another stain which is present in myeloblast and lymphoblast, but the characteristic dot like positivity is seen in T ALLs. So flow cytometry is another investigation which is commonly used to identify the blast and identify the lineage of the blast, and helps us in the subclassification of acute leukemias. So what is flow cytometry? It is a technique in which the cells are stained with fluorescent dyes, and if the antigen is present, it binds to that cell surface. We can use even intracytoplasmic markers, and after the cells staining, it is passed through a chamber or a flow cell, and a laser light is passed through it to stimulate the fluorochrome. So if the antigen is present, it binds to the antibody and it shows up as presence of fluorescent molecules. So CD45 is a commonly used marker. It is a common hematopoietic marker. So the intensity helps us differentiate between different types of cells. The blasts, the lymphocytes are the ones seen here, which is blue. They have the brightest expression. In blasts, they are positive for CD45, but they are of lesser intensity. And CD34 is another marker which is commonly seen or positive in the blast. So this red population is the blast population, which is positive for 34, whereas the other populations are negative. So in flow cytometry, we identify blast using immaturity markers like CD34 TDT, and we assign the lineage using other markers. For example, in B, you have CD19, CD10. In T, we can have CD3. In Myeloblast, you have CD13, 33, etc. So B cell lineage commonly used markers are 19, 10, 17 in alpha. In T, CD7, CD5, CD3, 4, 8. Whereas in myeloid, the positive markers are 13, 33, 117, etc. So we can see a few typical cases of acute leukemias and the flow cytometry pictures. So if you can concentrate on the red population, here CD45 is dim and it is positive for CD34 and CD117. So CD117 is a myeloid marker, and you can see CD33 is positive. So the red population is on the right hand side. So this indicates acute myeloid leukemia. This is another case where you can see the red population, which is CD45 dim, and it is showing positivity for CD19. So you can see CD19 here, it is on the right side, so it is positive, and it is positive for CD34. So on the y-axis, it is on the higher side, and it's positive for CD10. So we have a population which is positive for B cell markers, CD19 and CD10, as well as CD22. And you can see CD117 and 13, which are negative. So this population is on the lower side of this y-axis, whereas on the left-hand side of this x-axis, so it is negative for 13 and 117, which are myeloid markers, and it is positive for B markers, CD19 and 10. So this is a case of B acute lymphoblastic leukemia. So this is another case where you can see this large blast population here, large cells, prominent nucleoli, and agranular cytoplasm. And if you look at the different pictures, I will just lead you on to the red population. So it is positive for CD5, and it is positive for CD2 and 7. So 2, 7, 5, they are all T cell markers. But if you see 19, which is negative, 13, and which is negative, so it is negative for B and myeloid markers. So this is a case of T acute lymphoblastic leukemia. So flow cytometry helps us in identifying the lineage of the blasts. Rarely you can have a mix of all these lineages, what we call a undifferentiated or mixed lineage leukemia. So cytogenetics is the study of chromosome structure and number, which is used for diagnosing and for prognosis of hematological malignancies, especially acute leukemias. This abnormalities could be translocations or aneuploidy, which we diagnose by looking at the karyotype of the chromosome. So this is how a normal karyotype or chromosome structure looks like. You have a pair of 23 set of chromosomes, and you arrange it number wise, and you look at the structure. In balanced translocations, what happens is one part of the chromosomes gets detached, and then it attaches with the chromosome, leading on to fusion of two different genes. Not all acute leukemias behave differently. There are different factors which decide the prognosis in a given case. For example, in AML, the most commonly used risk stratification is the NCR, the National Cancer Institute risk stratification. Here, age and WBC count are important. Age less than 1 year and more than 10 years are associated with poorer prognosis, and WBC count at presentation more than 50,000 is associated with poorer prognosis, whereas age between 1 and 10 years and a lesser WBC count and hyperdiploidy using cytogenetics is associated with favorable prognosis. In the present days, response assessment is done after the initial period of chemotherapy. So if the abnormal lymphoblasts are present after the initial induction phase of chemotherapy, this is called a residual disease, and the presence of this disease is associated with poor outcome. In AML, acute myeloid leukemia, cytogenetics and genetic factors are more important in risk stratifying a case, which can be favorable, intermediate, or adverse. Favorable categories include translocation 821, inversion 16, and translocation 1517, which is acute promyelocytic leukemia. We saw that this is a very aggressive disease, but because of the presence of therapy available, this falls under the favorable group. Whereas adverse groups include inversion 3, translocation 6, 9, and monosomy 7 and complex karyotype. So we use cytogenetics and molecular genetic markers to subclassify this acute myeloid leukemias. Broadly coming to the treatment, most commonly a combination of chemotherapy drugs is used. Different regimens are used for acute lymphoblastic leukemias and acute myeloid leukemias. And for acute promyelocytic leukemia, we use ATRA and ADO, which is all trans-retinoic acid, and arsenic trioxide, which helps in the differentiation of acute promyelocytic leukemia. Recent days, we have targeted therapies both against cell surface markers as well as different genetic mutations, and in relapse cases or patients who are not responding to conventional therapy, bone marrow transplant needs to be considered. So I end here. So this is about acute leukemias, and thank you all for your attention.
दूसरी पीपीटी कहाँ से बंद तो नहीं किया ना सर उसे?
नहीं, इसको तो बंद नहीं किया। ये क्या दूसरा ऐसा स्ट्रीम लगा था? ये कैसे जाएगा?
देख लो सर, अगर एक ही में तो कंटिन्यू कर दो सर, कोई दिक्कत नहीं।
ठीक है, चलो।
F5 दबा दो सर। ठीक है सर।
So we'll continue the second class, which is chronic lymphoproliferative disorders. So before going into the class proper, so we'll look at the different terminologies used in the context of this group of disorders. So I'll just go through the few terminologies which are related but can be slightly different. Chronic lymphoproliferative disorders, lymphomas, mature lymphoid neoplasms, indolent lymphoid neoplasms, high grade and low-grade lymphoid neoplasms, small cell lymphomas, large cell lymphomas. So people use different terminologies. These are interrelated group of disorders. So all of this arises, all of these are neoplasms arising from mature lymphoid cells. When you say mature lymphoid cell, which is a cell which is not a lymphoblast but which is a mature lymphocyte seen usually in the peripheral blood. So this is the picture to show the differentiation of the hematopoietic lineage cells, starting from the hematopoietic stem cell to progenitor cell, which could be lymphoid or myeloid, and maturer cells, which could be lymphocytes, granulocytes, neutrophils, eosinophils, red blood cells, RBCs, and platelets. So this mature lymphoid neoplasms, of which chronic lymphoproliferative disorders are a group, arise from this particular category, that is B lymphocytes or T lymphocytes or plasma cells. So plasma cell neoplasms, of which multiple myeloma is a group, which has specific set of disorders which we will not be discussing in this class. We have a separate class for that. So in this class we look at neoplasms arising from B lymphocytes and T lymphocytes. So this is another picture to show how the cells differentiate or develop. So you can have cells in the bone marrow or thymus. Usually the B cell development happens in the bone marrow in the initial stages, and in the later stages it moves on into the peripheral lymphoid tissue, of which lymph node is an important structure, whereas majority of the T cell development happens in the thymus, and later on it moves on into the peripheral blood and lymph node. So if the neoplasm arises from the earlier cells, B cells or T cells, so if it arises from the B cells, it leads on to B lymphoblastic leukemia, and from the earlier stage of T cells it leads on to T ALLs, whereas in the later stages abnormalities or neoplasms arising from these cells leads on to chronic lymphoproliferative disorders, which include SLL, CLL, mantle cell lymphoma, etc. Similarly, when the neoplasms in the T cell lineage arises from the later cells, this leads on to peripheral T cell lymphomas. So this is the WHO 2016-17 classification of B and T mature lymphoid neoplasms. As you can see, this is a very big extensive list. You might not be able to see all different subtypes. So this include commoner ones like chronic lymphocytic leukemia, small lymphocytic lymphoma, and splenic marrow cell lymphoma, follicular lymphoma, lymphoplasmacytic lymphoma, etc. This also comprises of diffuse large B cell lymphoma, in which the cells look morphologically bigger, and in the T and NK cell lineage again you have different subtypes. So it is a very big exhaustive list, but in this class we will just look at the commoner subtypes and the features associated with the commoner subtypes of B and T lymphomas. So as we just saw, the broad classification includes two lineages: B mature lymphocytes, which the neoplasms of which are called B mature lymphoid neoplasms, or T and NK cells, and the neoplasms arising from them are called T and NK cell mature lymphoid neoplasms. And in each category we will look at the clinical features, the basic pathogenesis, and the morphology of the cells, both in peripheral blood and bone marrow, and also in the bone marrow biopsy. And we will also look at the immunotyping of these cells, which can be done by either FCM flow cytometry or immunohistochemistry, and additional investigations including cytogenetics, FISH, and molecular genetic studies are necessary, both for the diagnosis as well as the prognosis of this group of disorders. We'll briefly touch upon the broad principles of treatment in the end. Starting with the B mature lymphoid neoplasms. So this is the exhaustive list of B mature lymphoid neoplasms. So this include commoner ones like CLL and follicular lymphomas, mantle cell lymphoma. So CLL, follicular lymphoma, margin zone lymphoma, and these are associated with smaller type of cells, smaller sized cells. So classically these are grouped together as chronic lymphoproliferative disorders or CLPDs, whereas the more aggressive ones like diffuse large B-cell lymphoma has large sized cells, and they usually have an aggressive course compared to this small cell lymphomas. So before going on to the specific subtypes, we'll see how we stage and grade this lymphoma. So staging and grading are two slightly different things. So stage is one in which you look at how far the disease has spread and how wide the disease has spread. The most commonly used staging classification is what we call an ARPER classification. This is commonly used for both Hodgkin's and non-Hodgkin's lymphoma. When you say non-Hodgkin's lymphoma, the CLPDs are a broad category within this, and the stage are from stage 1 to 4, and then we have the subgroups A and B. So stage 1 is where only one lymph node region or group is involved. This could be just a group of right cervical lymph node or left inguinal lymph node, or just one group or region of lymphoid structures, either the presence of spleen or in stage 2 we have two or more lymph nodal regions, but these are present on one side of the diaphragm. For example, you can have just one group of lymph nodes in the right cervical region, and you can have another group of lymph nodes in the right axillary region, but both are present above the diaphragm. In stage 3, you have two or more lymph nodal groups, but these are limited to lymph nodes and lymphoid structures, but these are present on either side of the diaphragm. So you can have right cervical lymph node and involvement of mesenteric lymph nodes, or you can have right iliac lymph nodes. So this indicates a much more spread compared to the earlier stages. In stage 4, the spread of the disease is extensive. It is usually beyond lymph nodes and the spleen to other organs like bone marrow or CNS, or in the distant organs. So stage 1 and 4 are depending on the extent of spread, and also in each category you can have subdivision into A or B. So you can have stage A, stage B, or you can have stage 3A and stage 3B, stage 1A, stage 1B. So how do we subclassify A and B? So B is one you have where you have specific symptoms. This include one or all or any combination of these three features. One is fever, and when we say fever, it's persistent more than 38, and there is significant loss of body weight, that is at least 10% body weight loss, which is unintentional in the last 6 months, and you have severe drenching night sweats. So when any or all of the symptoms are present, it becomes B, and when none of the symptoms are present, we call it A. Grading is another factor which needs to be taken into account when studying lymphomas. So there are different types of grading for different types of lymphomas. The most commonly used grading is the IPA grading, where you have different categories which include age, stage of the disease, extent of extranodal spread, and the performance status and LDH levels. So if you see here, the presence of each of these factors gives a score of 1, and if it's absent, then it's a score of 0. And in the end, you add up all the scores. So when it is on the higher side, like 4 or 5, it is a high risk disease. The grade is high risk, whereas in the scores are lesser, you have a low risk category. And the CLPDs are diseases which involve all or a combination of peripheral blood, bone marrow, lymph nodes, spleen, and liver. One or all or combination of all these organs are involved, and when they involve the bone marrow, it indicates widespread disease. And there are different patterns of bone marrow involvement. So this is a normal bone marrow where you have hematopoietic cells and fat. When the involvement is paratrabecular, you can see this blue lymphoma cells. They are attached or they are adjoining the bone marrow. So this type of involvement is a paratrabecular involvement. Interstitial is one where it is away from the bone marrow and in the bone marrow spaces, but not in the bony trabeculae. Nodular is the one in which there is round nodular aggregates present in the marrow spaces in between the bony trabeculae. It could be intrasinusoidal, that is present within the blood vessels in the bone marrow, or the pattern of involvement could be diffuse or packed marrow, where the cells are seen in sheets throughout all the spaces in the bone marrow. So paratrabecular is one which is commonly seen in follicular lymphomas, rarely seen in other types, but classical or characteristic of follicular lymphomas. Non-paratrabecular is seen by other small lymphoid NHLs. Intravascular or intrasinusoidal involvement is involvement of blood vessels within the bone marrow, and it is commonly seen in SMZ or splenic marginal zone lymphomas and intrasinusoidal large B-cell lymphomas. And diffuse interstitial and solid involvement is seen in other types of lymphomas. So we use a different type of markers. This could be cell surface or intracytoplasmic or intranuclear markers to identify and subtype different type of CLPDs. This could be done by flow cytometry or by immunohistochemistry. So flow cytometry is done from the liquid sample, peripheral blood or bone marrow aspirate, whereas IHC we use bone marrow biopsy. For B lineage identification, we need CD19, 23, 22 surface kappa and lambda, and for T we need T surface markers, CD3, CD7, 4, 8, 15 and 66 for NK cells, etc. So we will see when we look at each category, how do we identify a particular subcategory and how do we differentiate that particular category. So we'll start with the B CLPDs first. The most common one is chronic lymphocytic leukemia or small lymphocytic lymphoma. When it is presenting in a leukemic picture, meaning with the lymphocytosis, it is called chronic lymphocytic leukemia. But when it presents as a nodal mass or it is presenting as a mass lesion, it is called a small lymphocytic lymphoma. This is characterized by accumulation of mature appearing lymphocytes in the blood, bone marrow, lymph nodes and spleen, and these are monoclonal B cells. So what are these monoclonal B cells? We'll come to it in a bit. So these are positive for CD5. So normally CD5 is negative in normal mature B cells. In CLL cells, CD5, though it is a T marker, it is present, expressed on these cells, which is classical of this CLL. It is a disease of old age, rare in children and young adults. Usually it occurs in age group more than 50 years, and the incidence increases with age. Most of these cases are preceded by a precursor lesion called monoclonal B cell lymphocytosis, in which similar abnormal B lymphocytes are present, but the numbers are much less compared to chronic lymphocytic leukemia. The exact cause is unknown. Many different theories have been proposed, including both genetic factors, which are host or patient intrinsic factors, as well as extrinsic or environmental factors. It is a very slow growing tumor, so what we call an indolent neoplasm. In fact, many patients have this disease for many years without having any symptoms at all, and they are diagnosed just on a routine examination. Though a few patients can have symptoms and they can have aggressive disease, but in general it is a indolent slow growing neoplasm. In this, increased tumor cell survival appears to be more important than tumor cell proliferation itself. So this is because they have increased levels of BCL2, which is a protein that inhibits apoptosis. So BCL2, as you would have learned in the general path class, it's a protein which is important in the apoptotic pathway. In CLL, there is increase in this BCL2 protein, which inhibits apoptosis, resulting in increased cell survival and increased number of this circulating lymphocytes. So one main mechanism of BCL2 overexpression is the chromosomal deletion that leads on to genes which encode for microRNAs, and these are negative regulators of BCL2. So signal generated by surface immunoglobulins, which are part of the B cell receptor complex, they communicate through the Bruton tyrosine kinase or BTK pathway that contributes to the expression of genes that promote the survival of CLL SLL cells. So basically that's increased survival of these lymphocytes, leading on to accumulation of these cells, resulting in increased numbers, mainly involving the apoptotic pathway. As we just saw, the clinical features are variable, but majority are usually asymptomatic, meaning they don't have any symptoms, and the disease is picked up incidentally. So in symptomatic patients, the most common complaint is fatigue, which is because of anemia mainly, and less commonly the patient can have enlarged lymph nodes because of involvement of because of proliferation of the cells within the lymph nodes, or you can have infection because of reduced neutrophil numbers. So you can have lymphadenopathy, splenomegaly. Hepatomegaly is can be present, but it's usually rare, and less common manifestations include involvement of other lymphoid organs like tonsils, mesenteric lymphadenopathy, etc. And if there is bone marrow involvement leading on to reduced production of hemoglobin and platelets, this can lead on to anemia and thrombocytopenia. So in CLL, the lymphocyte count or the absolute lymphocyte count is above 5,000 cells per cubic mm. The morphology appears that of a mature small lymphocyte, and there are many cells which have lost the cytoplasm, which what we call a smudge cells seen on the peripheral blood smear, which is characteristically seen in chronic lymphocytic leukemia. A good examination of the blood smear can differentiate CLL from other subtypes, and immunophenotyping using flow cytometry is used for confirmation. So this is a blood film of a patient with CLL. As you can see, there is increase in lymphocytes. In this blood film you see just lymphocytes, you can't see much of neutrophils, and if you can see, this is a cell which appears like a normal mature lymphocyte, because the size of the cell is almost equal to the red cell, and if you see the cytoplasm, which is very scanty and agranular, and in the nucleus if you see, there are alternating dark and white patterns, what we call a soccer ball chromatin, and this is a cell which basically has lost its cytoplasm and looks like a degenerated one. So this is what we call a smudge cell, which are commonly seen in the case of CLL. So this is the nuclear material which has been spread onto the blood film. So the presence of small mature lymphocytes along with the smart cells helps in the diagnosis of chronic lymphocytic leukemia. The lymph node can, if involved, can have different patterns. It can have diffuse involvement or small proliferation centers, and the individual cells themselves are small mature lymphocytes with soccer ball chromatin. In the laboratory testing, we see increase in the B lymphocytes. The B lymphocytes are positive for CD19 and 5. So normally B lymphocytes show CD19, which is a B cell marker, but CD5 is absent. Whereas in the case of CLL, CD5 is abnormally present, and which helps in identification of this subtype of CLPDs, and it is a clonal process. So when we say clonality, it means the presence of only kappa or lambda on the cell surface. So in a normal individual, there is presence of both kappa positive and lambda positive cells in the peripheral blood, whereas in the case of CLL, there is proliferation of one subtype resulting in presence of only kappa positive cell or only lambda positive cell. So when kappa positive cells are present, the lambda positive cells are predominantly absent. So this is what we call clonality, and it is common to all lymphomas and the CLPDs, including CLL. Very frequently they have rearrangements in the immunoglobulin genes, and hypoglobulinemia or A-gamma globulinemia is a commonly observed feature because of dysfunction of this lymphocytes. So B lymphocytes develop onto plasma cells, and they produce large amount of gamma globulins, but when they are dysfunctional, this leads on to reduced production of these gamma globulins, which leads on to infections. A small proportion of these patients develop autoimmune hemolytic anemia, which is diagnosed using a specific test called a direct AIIMS test. This is because antibodies are produced against the red cells, resulting in lysis of these red cells. Usually the diagnosis can be done from the peripheral blood. Bone marrow is done sometimes, and this also, if done, shows increase in mature lymphoid cells. So not all increase in lymphocytes is due to CLL or chronic lymphocytic leukemia. We have many other causes, including both infectious and malignant causes, which can cause increase in lymphocyte count. This include infectious causes like bacterial, tubercular, and viral infections, which also can have increase in lymphocytes. So we need to keep this in mind when we evaluate a case of lymphocytosis. Other malignant neoplasms can also lead on to increase in lymphocyte counts, which we'll see subsequently. So it is other non-Hodgkin's lymphomas like follicular lymphoma, marginal zone lymphoma, mantle cell lymphoma, etc. Hairy cell leukemia, Waldenstrom's, and LGLs can also have increase in lymphocytes. So what are the investigations we do in a case of CLL? So before treatment, it's good to do a battery of investigations, including a complete blood count. We will know if anemia and thrombocytopenia is present, and what is the WBC count and what is the lymphocyte count, and it helps us in calculating the absolute lymphocyte count. In CLL, the absolute lymphocyte count should be more than 5,000. We need to look at the stained peripheral blood film to look for the morphology of the CLL cells. Reticulocyte count to look for reticulocytosis, and AIIMS test to see if there is any AIIMS positive hemolytic anemia, and routine tests including renal liver function tests and the serum protein electrophoresis to look for monoclonal component. So immunophenotyping or flow cytometry is done to confirm the diagnosis. So mainly we look at CD5 positivity in the B cells, and cytogenetics and FISH can help in knowing the classical cytogenetic abnormalities associated, and also help us in guiding therapy. And bone marrow biopsy and aspirate can be useful for cytogenetic analysis. Staging of CLL is important. Two different staging systems are used. One is Roy classification and the other is the Binet classification. In Roy classification, we have stages 0 to 4, depending on the presence or absence of different clinical and lab features. In stage 0, it is just lymphocytosis. There is no lymphadenopathy, no organomegaly, and the hemoglobin and the platelet count are normal. Whereas in stage 1, in addition to lymphocytosis, you have lymphadenopathy. Whereas in stage 2, in addition to lymphocytosis, there is presence of splenomegaly. Lymphadenopathy may or may not be present. Till stage 2, there is no anemia or thrombocytopenia. If either of this is present, then it becomes stage 3 or 4. In stage 3, anemia is seen. Here the hemoglobin is defined as less than 11 grams per deciliter. The patient may or may not have lymphadenopathy or splenomegaly, but usually these are present. In stage 4, in addition to lymphocytosis, you have thrombocytopenia with platelets less than a lakh, and you may or may not be associated with other features. In Binet classification, it's classified into stage A, B, and C, depending on the number of lymph nodal regions involved, and in the presence or absence of hemoglobin, plus anemia and thrombocytopenia. If anemia and thrombocytopenia are present, it becomes stage C, and if they're absent, then we look at the number of lymph nodal areas. So this lymph nodal area meaning whether right cervical lymph node is involved and axillary lymph node is involved, inguinal lymph node is involved. So presence of 3 or more regions, it is stage B, whereas in stage A, it's less than 3 regions. So why this is important? Because the later stages are associated with poor survival, whereas in the early stages, the survival or the prognosis is much better. So different markers of prognosis, including advanced stages and peripheral lymphocyte doubling time, if it is shorter, diffuse marrow involvement, and presence of chromosomal abnormalities like deletion 7p and p53 mutations, which makes the patient poorly respond to chemoimmunotherapy, and presence of Richter transformation, meaning CLL has evolved into a large B-cell lymphoma. So all these cases are markers of poor prognosis. And many of the patients have cytogenetics or FISH abnormalities. Common ones are trisomy 12 and deletion 13 and abnormalities in 14, 11, etc. 17p deletion is an important chromosomal abnormality, as it guides us in choosing one therapy or the other, because they have poor response to the commonly used FCR therapy. So in treatment, so not all patients of CLL require treatment. Many asymptomatic patients, we don't need any treatment at all. We just wait and watch or observe them for long periods. A few patients become symptomatic or progressive disease, meaning the disease keeps on evolving and they have symptoms due to anemia, bleeding, mass lesion, etc. In that case, treatment is required, and we use different types of treatment regimens, which the common ones are combination of chemotherapy and immunotherapy, like FCR, including rituximab, which is anti-CD20 molecule. Different monoclonal antibodies can be used, and newer therapies including venetoclax and ibrutinib are used for therapy, especially those with deletion 17p. So this is about CLL. CLL is the commonly seen chronic lymphoproliferative disease, CLPD. Other lymphoid neoplasms can also be present in different individuals. We'll just quickly go through the most important ones. First, we start with follicular lymphoma. As the name suggests, in the lymph node biopsy, the involvement of this lymphoma results in different sized follicles, and it's a B neoplasm of follicular central cell origin, and it has a follicular pattern of growth, and it is associated with typical chromosomal abnormality, that is translocation 1418. So this translocation 1418 can be picked up by either cytogenetics or fish. And in flow cytometry or immunohistochemistry, this shows positive CD10 expression and BCL2 and BCL6. So in comparison, the earlier we saw CLL, which is CD10 negative, but this follicular lymphoma, it is CD10 positive. So what are the different types of cells which are seen morphologically? So this could be cleaved cells or large non-cleaved cells. So what we call centrocytes and centroblasts. So these are two main types of cells. It could be a combination of these two cells or just presence of one cell. It is commonly, it's one which commonly involves the bone marrow with characteristic paratrabecular involvement. It is a slow growing tumor and indolent, meaning it's not very aggressive. So because it's not aggressive and slow growing, it has a long survival with good response. Rarely this is followed by transformation to high grade lymphoma, which becomes aggressive. Patients can have spleen and liver involvement, and many have bone marrow involvement. So this is the lymph node biopsy to see different sized follicles involved by follicular lymphoma. Whereas in other cases you see diffuse involvement in other lymphomas. Grading system is used based on the presence or absence of centrocytes and centroblasts, whereas in grade 1 it's predominantly centrocytes, which are small mature cells with cleaved nuclei, whereas in grade 2 it is mainly centroblasts, which are large cells with prominent nuclei. In grade 3A it is present in large numbers and sometimes in sheets. What do we see in the peripheral blood and bone marrow in this case of lymphoma? So blood count and blood film are mainly normal because it's mainly involves the lymph node and the bone marrow, but rarely you can have involvement in the peripheral blood. When bone marrow involvement is present, there is reduced hemoglobin, reduced platelets and reduced neutrophils. A large portion of the patients show bone marrow involvement. So this is the characteristic morphology of these cells. So this picture shows case of follicular lymphoma. The important morphological feature is the presence of these lymphocytes with this cleaving or indentation. So you can see the nucleus here and scan cytoplasm. But if you see the nucleus, sorry. Excuse me. If you see the nuclear margins, you can see a groove or a cleave running through the nucleus. So this cleaved nucleus is a characteristic feature of follicular lymphoma. This is the picture to show the bone marrow involvement, where we can see this follicular pattern of involvement, and also this is the bony trabeculae. So you can see the presence of these blue cells adjacent to the bony trabeculae, what we call a paratrabecular involvement, which is characteristic of follicular lymphoma. So this is the flow cytometry picture to show the immunophenotypic markers of follicular lymphoma. So it is a B cell lymphoma, so B markers are present, 19, 20, 22 are present. So as you can see, this group marked by an arrow, it shows positivity for CD20, which is a B cell marker, and positivity for CD19, which is a B cell marker. And in addition, it is positive for CD10. So you can say CD10 is here, so it is positive for CD10. So this is a neoplasm which shows B cell markers in addition to CD10. Cytogenetics, we look at the chromosome number and structure. So here if you see chromosome 14 and 18, there is loss of chromosomal material here, where there is some gain here. So this translocation of chromosomes 14 and 18 which leads on to juxtaposition of BCL2 gene onto the immunoglobulin heavy chain on chromosome 14. So this leads on to the pathogenic features associated with the follicular lymphoma. This translocation 14-18 is the most commonly seen abnormality. Less commonly other abnormalities are seen, and BCL2 rearrangement is seen fairly commonly, followed by BCL6 rearrangement. And we looked at the flow cytometry or immunophenotyping. So this is the B cell neoplasm. So B markers like 19, 20, 22 are present. CD10 is present in large number of cases. CD5 is negative. So in comparison, CLL is CD5 positive. And we can use immunohistochemistry to study the B cell markers. The immunohistochemistry shows positivity for CD20, CD79A, PAX5, BCL2, etc. And CD5 and CD23 are negative. These two are classically positive in chronic lymphocytic leukemia. Follicular lymphoma is a low-grade neoplasm, but it can become aggressive and transform into a high-grade lymphoma in a few cases. Then it behaves like a DLBCL. Next, we move on to the next group of disorders, mantle cell lymphoma. So compared to the previous two lymphomas, it is an aggressive lymphoma, which is characterized by monomorphic appearing cells with the irregular indented nuclei, and it has a characteristic immunophenotype profile. So it is CD5 positive. In that way, it is similar to CLL. CLL is also CD5 positive. CD20 is positive. So all the B lymphomas are CD20 positive. CD23 is negative. In comparison, CLL is CD23 positive. And the characteristic feature is the overexpression of cyclin D1 because of juxtaposition of cyclin D1 gene to the immunoglobulin heavy gene, heavy chain gene. So this overexpression of cyclin D1, which can be seen in flow cytometry or immunohistochemistry, is a characteristic feature of mantle cell lymphoma. The most common cytogenetic abnormality which is characteristic of this disorder is translocation 11-14, and this leads on to overexpression of cyclin D1. So what does cyclin D1 do? It stimulates growth normally by promoting progression of cells from G1 phase to S phase. So this is kept in normal check in the normal lymphocytes, whereas overexpression of this leads on to uncontrolled stimulation leading on to mantle cell lymphoma. It is a less common CLPD compared to other CLL and follicular lymphomas. The age group is middle age to older age group, and it arises from the pre-germinal center naive B cells. Bone marrow involvement, hepatosplenomegaly are fairly common in this group of lymphoma, and different morphological variants are seen. This could be blastoid, resembling acute leukemia, and it could be pleomorphic, different types of cells and with highly variable morphology, and it can also be comprised just of small cells mimicking CLL or SLL, and it could be marginal zone like paratrabecular diffuse or interstitial. So this is the section to show the morphology of this mantle cells. These cells are larger compared to CLL cells, which have many of them have this prominent nucleoli, and the cell size is larger compared to CLL. And this is the immunohistochemistry for cyclin D1, where you can see this brown positivity within this nucleus of this cell. So cyclin D1 is a nuclear stain. Overexpression of this is characteristic of this mantle cell lymphoma. And coming on to flow cytometry, this shows positivity for B cell markers CD19 and CD20. As you can see, CD20 is here, the tumor cells are shown by the arrow, and they are all positive, and they show monoclonality or surface light chain restriction. So what do you mean by monoclonality? So they are present only for either for kappa or lambda. Here they are present just for lambda. So you can see this lambda is positive, this kappa is negative in these cells, and they are negative for CD23. So the flow cytometric immunophenotyping is 5 positive, 19, 20 positive, 22 positive. So all the B markers are positive in addition to CD5, which is a T cell marker. So CD5 positivity is seen in two types of CLPDs. One is CLL and second is mantle cell lymphoma. And the same immunophenotype can be confirmed with immunohistochemistry also. And characteristic cytogenic abnormalities translocation 11-14 and BC cyclin D1 rearrangement. This is the cytogenetics to show 11-14 translocation. So there is loss of chromosomal methylene in chromosome 11, which is translocated onto chromosome 14. Blastoid variant is a very aggressive variant with less survival and which has elevated mitotic counts and increased proliferation index. So blastoid variant of mantle cell lymphoma is one of the variant which shows very aggressive behavior. Next we move on to a very characteristic group of lymphomas. Burkitt's lymphoma, they don't classically come under the category of CLPDs, but I'm including this because you don't have another class for Burkitt's lymphoma and DLBCLs. So this is an aggressive B cell lymphoma with mature B cell phenotype and characterized by very bulky disease, extranodal proliferation and very high degree of proliferation. So Ka67 is one which indicates the degree of proliferation. So in this group of lymphomas, there is very high degree, so the Ka67, very high degree of proliferation, so the Ka67 index is almost 100%. So different types are seen, which could be endemic, sporadic or immunodeficiency associated, and EBV is one of the causative factors, and it is because of translocation involving the MYC gene, which is a central gene to this group of disorders on chromosome 8. And it is a MYC gene, as you would have read in general path section, it is a master regulator of Warburg metabolism associated with rapid cell growth. It is a very fast growing tumor associated with a very high Ka67 or proliferation index, resulting in fusion of MYC with the IGH gene. There are three types: endemic, sporadic and immunodeficiency associated. And endemic is mainly seen in Africa, whereas sporadic is seen in different parts of the world, and it's common tumor seen in it's a tumor commonly seen in young children, whereas immunodeficiency associated is seen in HIV positive individuals. The immunodeficiency associated frequently involves the lymph nodes and bone marrow, whereas the endemic and the sporadic ones are commonly extranodal, whereas the endemic one also has a predilection for jaw and facial bones. And association with EBV is commonly seen in the endemic ones and considered as a causative factor. The cells have a characteristic morphology in the sense the cells are large, appear blast-like, with abundant cytoplasm, and very importantly they have lot of vacuoles. So this is a cell, you can see this white small structures within the cytoplasm. So there is a lot of vacuoles in the cells, which is characteristic of Burkitt's lymphoma. In a lymph node biopsy, you can see a lot of histiocytes which appear as pale structures in between the tumor cells. So the background blue colored cells are the tumor cells. In between you have this whitish histiocytic structures. So this is what we call a starry sky pattern. So in the dark sky you have this white shining histiocytes leading into a starry sky pattern, which indicates high proliferation and high turnover, and the histiocytes are just to eat up the apoptotic cells. And this this morphology is characteristic of Burkitt's lymphoma. And characteristic 8-14 abnormalities are seen in this group of disorders, and there is fusion of MYC gene which IGH gene, this is the immunoglobulin heavy gene, so translocation involving 8 and 14, which is seen in majority of the cases, but in a small amount of cases you can see translocation involving 2, 8 and 822. So basically MYC gene is on chromosome 8, whereas 2 and 22 contain this immunoglobulin light chains kappa and lambda, and translocation involving these kappa and lambda light chains can also occur in the case of Burkitt's. So immunophenotype, it is CD. You can see the cells here. You see 20 positive and they are 10, 19 and 10 positive. So this tumor again is 10 positive and 5 negative. So it is a 19 B cell markers are positive because it is a B cell tumor, 19, 20, 22 and 17 in alpha, and 10 is positive in large proportion of cases. 5 and 23 are negative. And in immunohistochemistry, similar pattern can be seen, presence of B cell markers including CD10, and more importantly Ki67, which is a proliferation index which is nearly equal to 100%. Coming to the next group of disorders, which is lymphoplasmacytic lymphoma. This is a characteristic group in which you have a large number of lymphocytes. So most of the previous CLPDs which we have seen, there is increase in mature lymphocytes. So here in lymphoplasmacytic lymphoma, you have a mixture of lymphocytes, plasma cells and lymphoplasmacytic cells. So in another extreme, you can see proliferation of just plasma cells, which is multiple myeloma, which we'll learn in another class. So lymphoplasmacytic lymphoma is like an intermediary between lymphoma and myeloma. So there are two terminologies: lymphoplasmacytic lymphoma, which is the lymphoma involving this cells having different morphology including plasma cells and lymphocytes, and there is something called Waldenstrom macroglobulinemia. This is a specific subset of lymphoplasmacytic lymphoma in which in addition we have this IgM paraprotein. So this lymphoma cells secrete IgM, which is IgM type of paraprotein, whereas in most other lymphomas the paraprotein is usually IgG. The clinical features include lymphadenopathy, splenomegaly, and cold hemoglobin disease caused by this specific IgM antibody, and the patient can have hyperviscosity syndrome. So IgM is a big antibody compared to IgG. Because of the increased size, the accumulation of this leads to hyper viscosity in the plasma and in the blood. So when the hyperviscosity occurs, there is blockage of small blood vessels, leading on to different manifestations like visual impairment and neurological manifestations, and even bleeding and Raynaud's phenomena can occur. So what is the basic pathogenesis underlying this group of lymphoplasmacytic lymphomas? So recently a specific gene called MYD88 or MYD88 has been identified as a pathogenic in this group of disorders. So the mutations in this MYD88 gene is characteristic of this lymphoplasmacytic lymphoma. And how does it work? It signals activation of NF-κ beta and increases the signaling using the BCR complex or basal receptor complex. So we need to remember this MYD88 gene, which is characteristically mutated in lymphoplasmacytic lymphoma. So how does this cell look like morphologically in the peripheral blood film? So you can see this cell, which is more like a combination of a lymphocyte and a plasma cell. So what we call a lymphoplasmacytic cell. So the cell is relatively smaller. It has an eccentric nucleus and scanty amount of cytoplasm, which is usually agranulate. And also the background, you can see agglutination of red cells, which is commonly seen in this group of disorders. Bone marrow is commonly involved. You can have different patterns of involvement, and this is the bone marrow where you can see a combination of different types of cells. You can see mature lymphocytes, you can see this plasma cells. So these are eccentric structures with the perinuclear half and elliptical cells with blue cytoplasm, and you can have cells which are intermediate between lymphocytes and plasma cells. And as I said earlier, IgM is commonly produced by these cells, and these cells show presence of both lymphocytes and plasma cells. So CD20 is a marker of mature lymphocytes, which is also positive, and again CD138 is a marker of plasma cells. This also shows positive, so you get positivity for both lymphocyte and plasma cell markers. Flow cytometry identifies the same, presence of 19, 20, and presence of IgM 5 and 10 are negative. Even in IHC, the B markers are positive, and you can have 138 and 38 positive, which are markers of plasma cells. These are positive in this group of lymphomas. Moving on to the next group of disorders, which is marginal zone lymphoma. The marginal zone lymphoma themselves are subdivided into different subgroups. This could be splenic, involving the spleen, nodal, mainly involving the lymph nodes, or extra nodal marginal zone lymphoma, or Maltomas. When you take other lymphomas, lymph node involvement is common, whereas here in marginal zone lymphomas, the lymph node involvement is less common. Spleen and extranodal involvement are commoner than lymph nodal involvement. So, extranodal marginal zone lymphomas are indolent neoplasms, and they occur at sites, extranodal sites, where there is chance for increased inflammation, like the gastrointestinal tract, salivary glands, lungs, etc. Stomach is a very common site, and the underlying pathogenesis is chronic inflammation seen in this group of disorders, which can be an autoimmune in the case of Sjogren, or in case of Hashimoto's thyroiditis involving the thyroid gland, or this can be because of chronic infection, as in H. pylori, gastritis, leading on to extranodal marginal zone lymphoma in the stomach. So the underlying pathogenesis is chronic inflammation, which could be triggered by either autoimmune conditions or by infections. And this is important to recognize because in a small proportion of cases, when the chronic infection is treated, like H. pylori treatment in case of stomach, a few cases in which the lymphoma has reverted back when the stimulus has been taken care of by antibiotics. So immunophenotype, they express surface immunoglobulins and B cell markers like 19, 20, 22, 17 alpha, etc. And they are negative for 5, 10, 23 or cyclin D1. So we can differentiate it from CLL, Mantle, lymphoplasmacytic lymphoma, etc. Next we go on to hairy cell leukemia. So it is an indolent neoplasm of small mature B cells. The characteristic feature is presence of hairy projections, which differentiate it from other lymphomas and CLPDs. And recently, most of the cases are found to have mutations in BRAF, which is serine kinase, and it arises from the memory B cell stage. It is a disease of older males, seen in age older than 50 years. It is very uncommon in children and young adults. It is a disease which commonly involves spleen. So massive splenomegaly is a commonly seen feature in hairy cell leukemia, and pancytopenia is also seen. So other leukemias, usually there is lymphocytosis here. Lymphocytosis is rare, seen in just 10%, 10 to 20%. Most of the cases there is pancytopenia, there is anemia, thrombocytopenia, in addition to reduced WBCs. This primarily involves the spleen and many times the bone marrow. Lymph node involvement is rare. Again, this is in contrast to other CLPDs and lymphomas where lymph nodes are frequently involved. It is indolent or slow growing in the initial stages, but if left untreated, it can become progressive, and it is extremely sensitive to nucleosides. If not, you can use BRAF inhibitors, as we just saw that most of these neoplasms are associated with BRAF mutations. This is the clinical picture to show a massive splenomegaly, which is characteristic feature of hairy cell leukemia. When you look at the lab findings, pancytopenia is seen in majority of the cases, and a specific characteristic feature is the absence of or reduced number of monocytes, what we call a monocytopenia. which is characteristic of hairy cell leukemia. And the diagnosis is usually made by looking at the morphological hairy cells, which are projections in the cytoplasm of the lymphocytes. So when you say the morphology, as we saw, the characteristic feature is the presence of thin cytoplasmic projections from the cytoplasm. Otherwise, the nuclear morphology is eccentric with central nuclei with fine convolutions. So this is the picture to show the lymphocytes here with moderate amount of cytoplasm, and we'll go to higher magnification where you can see this small cytoplasmic projections coming out from the cell or cytoplasmic borders. This is the EM picture to show different projections coming out from the cytoplasmic borders, and this is the scanning electron microscope where you can see this projections which are protruding out in the form of a hair, giving its name of hairy cell leukemia. And one specific cytochemistry, trap tartrate resistant acid phosphatase, is characteristically seen in hairy cell leukemia. In the bone marrow, the involvement can be diffuse or focal, and the morphology is similar to what is in peripheral blood, but in the biopsy there is presence of this fried egg appearance. So what is this? So this is the presence of central placed nucleus and then surrounding a cytoplasm or a halo. So this gives rise to the appearance of a fried egg. So we have a center blue dot, the nucleus, surrounded by a empty halo. So this fried egg appearance is a feature which is characteristic of hairy cell leukemia, and it has increase in pericellular fibrosis, which is seen on reticulin stain. It has a characteristic immunophenotype or a flow cytometry finding. So it is positive for B cell markers 19, 20, 17 alpha 22, and it is positive for hairy cell markers. These are 11C, CD25, 103, and Annexin A1. So the presence of 11C, 103, CD25, these are features which are specific for hairy cell leukemia, and these are usually negative in other type of lymphomas and leukemias. So here you can see a immunophenotype flow cytometry plot where just concentrate on this cells, group of cells. They are 19 positive, and you can see CD103, they are positive for CD103 as well. This group is negative for both. So again, if you see this plot, this group of cells, they are 19 positive and they are 11C positive, they are 25 positive. So this group of cells are positive for 11C, 103 and 25. So this is a feature specific for hairy cell leukemia. Less common lymphomas, they can involve the spleen, hairy cell leukemia variant, and splenic marginal zone lymphoma is another marginal zone lymphoma which is restricted to the spleen. So this is a table to compare the different types of lymphomas which we saw here. So SLL, CLL comprises 30% of all leukemias, and follicular lymphoma 40%. So these two are the common lymphomas in adults, and these are composed of small mature lymphocytes, and CD5 is positive in SLL and also mantle cell lymphoma, whereas follicular lymphoma is CD10 positive. And many of them are associated with characteristic cytogenetic abnormalities, like follicular lymphomas associated with translocation 14-18, and mantle cell lymphomas associated with translocation 11-14. Next, we'll quickly go through DLBCL, which is not included in the topic of CLPDs, but because there is no separate class, I will just highlight a few important features. It is a lymphoma which is common in adults, accounting for 35% of the adult non-Hodgkin's lymphomas. There are several subtypes in this, so this is a broad category for different subtypes of lymphomas. And what is common to them is the presence of large sized and aggressive looking B cells and an aggressive clinical course. So based on morphology, it could be centroblastic, immunoblastic, or rare morphological subgroups. In molecular subgroups, it's broadly divided into germinal center B cell like, which has a good prognosis, and activated B cell like. these are the specific subtypes, but I will highlight 3 different subtypes because they're mentioned in Robbins. So EBV positive or EBV associated DLBCL is one which is seen in the immunocompromised setting, like those in patients with AIDS or those on immunosuppression after transplant and in elderly. And primary efficient lymphomas are one which are large B-cell lymphomas associated with viral infections like Kaposi sarcoma virus. They are rare and they usually involve the serocell or the pleural or the body cavities like pleural cavity, pericardium, etc. Usually, otherwise the DLBCL is a disease of the lymph nodes. And mediastinal large B-cell lymphoma is a group which commonly occurs in women and show predilection for spread to abdominal viscera and CNS. So we saw there are 2 molecular groups, germinal central B-cell-like and activated B-cell-like. It depends on the overexpression of different genes and immunophenotype, and it is good to remember that GCB or the germinal central B-cell type has a better survival rate compared to the other group. So that's for the B-cell neoplasms. So we quickly go through common types of T and NK cell neoplasms. As such, T and NK cell neoplasms are less common compared to B neoplasms, but there are few distinct subtypes in this. Again, if you look at the WHO classification, there are many different subtypes of these neoplasms. I'll go through the commonly seen ones. Coming to mycosis fungoides and Sézary syndrome, it is a CD4 positive neoplasm and commonly involving the skin. The presentation of cases with plaque or tumor phase MF. So patients present with early phase have a good prolonged survival, whereas in disease phase or in Sézary syndrome, the survival is much lesser. So coming to the next group of disorders, adult T-cell leukemia lymphoma. This is important because it has a virus as its causative factor. T-cell pro-lymphocytic leukemia, here the morphologically the cells look like pro-lymphocytes and it's a very aggressive lymphoma. It is positive for 2, 5, 7 and 3. The membrane expression of 3 may be weak and 52 is positive. Another subgroup is T-cell large granular lymphocytic leukemia. The characteristic feature here is the morphology, where you can see this granules within the lymphocyte. So this is a large lymphocyte with granules. Normally lymphocytes are small with scant cytoplasm without any granules, but large. A few proportion of this lymphocytes are large lymphocytes, and tumor arising from this large granular lymphocytes is a T large granular lymphocytic leukemia, which is defined as increasing large granular lymphocytes in the blood, which is persistent and count more than 2000. Usually it can go up to 20,000, and it shows presence of T cell markers CD2, 3 and 8 and associated with STAT3 and STAT5 mutations. Tumors can arise from NK cells, which are natural killer cells. We call this chronic lymphoproliferative disorder of NK cells, and their markers are CD16 and 56. So this CLPD of NK cells are positive for 16 and 56, but they are negative for CD3, which is a T marker. PTCL or peripheral T cell lymphoma is a heterogeneous group of disorders, and this includes different subtypes. Mostly they are aggressive, poorly responding to therapy. Other specific subtypes include enteropathy associated T cell lymphoma, which occurs usually in a background of celiac disease, hepatosplenic gamma delta T cell lymphoma, which is a gamma delta type of T cell lymphoma, which is again very aggressive disease involving the liver, spleen, seen in young individuals with a very poor prognosis. Many T cell lymphomas specifically involve the skin. We saw mycosis fungoides area. Another one is a primary cutaneous CD30 positive T cell lymphoma, and other T cell lymphomas including angioimmunoblastic lymphoma, which cause proliferation of B cells and increased immunoglobulins, and anaplastic large cell lymphoma, which is a group of lymphomas in which the ALK is positive and which has very bizarre anaplastic cells. So we are coming to the end. This is from Robbins. As you can see, each group of lymphomas or CLPDs have a specific abnormality which is responsible for the pathogenic behavior of this neoplasms. Like for example, in Burkitt's lymphoma, you have MYC translocations which deregulate cellular energetics. You have BCL2 translocations in follicular lymphoma which resists cell death, leading to increased cell survival. And cyclin D1 translocations in mantle cell lymphoma, leading on to sustained proliferative signals. So each lymphoma has specific underlying pathogenetic abnormalities which help in the proliferation of these lymphomas and also help us in diagnosis of these lymphomas. So this is the end of this class on lymphomas and chronic lymphoproliferative disorders, and thank you for your attention and wish you all the best.